Good morning for the people in the West Coast. Welcome to day 2 of the scientific workshop on addressing the influence of interpersonal biases on health outcomes and disparities. I'm Carlos Garrido, and I'm chairing the event. It is my pleasure to welcome you back to what promises to be an engaging and enlightening experience, just like in day 1. We're thrilled to have an equally exciting lineup of distinguished speakers and discussants as yesterday, each bringing their unique expertise and insights to the table. Thank you for being here. So just to include the workshop objectives, the objectives are to bring together subject matter experts to enhance the understanding of mechanisms and pathways linking biases, exposure to adverse health conditions and disparities, to inform about the current state of the science, and to identify research gaps and opportunities, and to strategize about future research directions that elucidate etiological processes and multi-level interventions. So just to summarize the day 1 activities, we started off with the NIMHD perspective by Dr. Monica Webb-Hooper. Then we heard an amazing keynote address by Dr. Sandro Galea. Then we had 2 thematic sessions, one based on etiology and mechanisms linking interpersonal biases in health, and the clinician's perspective on addressing interpersonal biases in clinical settings. We then broke out into 3 different groups based on themes. The 3 teams were etiology and mechanisms, methods and measurement, and intervention-based approaches. So just to provide you with some high-level reoccurring themes that we learned about yesterday, just to summarize day 1's generation of knowledge. So the first theme were understanding identities, emphasizing the need to acknowledge where the biases originate, who we are, where we come from, and how our identities shape us. It is crucial to recognize that our identities may not align with those of others and to avoid making assumptions based on your own experiences. Also, the complexity of intersecting identities and their unique experiences with bias and coping mechanisms is significant. Identity is not only monolithic, even among people with shared identities and experiences. Experiences may differ based on those identities. So how an individual presents themselves can impact their treatment and current methods to address these issues. These methods are likely insufficient. As we heard from the first thematic session, the field is basically grappling with how to best measure interpersonal biases quantitatively. The second theme addresses the tension between the individual and the societal context and change. So we need models that adapt to the individual context and the structural changes to make individuals feel safe and reduce stress. So for instance, perceived safety, as we learned for the first thematic session yesterday, is associated with maladaptive cardiovascular reactivity, as is rejection sensitivity. So a research framework that merges individual and societal context is essential, such as the NIMHD framework. There's tension between solutions at the population level and at the individual level. So relying solely on addressing implicit bias at the individual level is inadequate, as research shows that it is difficult to change. However, implicit bias has been a good starting point for these conversations, but a multifaceted approach is needed to address these issues comprehensively. The next theme is we discuss the need for clear frameworks and objective measurement models. So ambiguity leads to reliance on ingrained stereotypes, resulting in biased care in clinical settings. So clear and objective frameworks lead to better decision-making. It is important to equip all members, in this case in clinical settings, including the front staff, tools to mitigate bias, making it a tangible skill. Instead of holding physicians accountable in punitive ways, we should provide scripts to help reorient patient conversations when bias is detected. Also, improving data-driven approaches and developing objective measures of bias, such as using bioinformatics and dyadic models, are also crucial. Building a workforce adept at collecting and using such data is necessary. Regarding clinician training and engagement, there's a need to better incentivize and engage physicians in bias training. Simply checking a box in annual training is insufficient. The primary goal should be to reducing the dissemination of bias, with changing minds as a secondary long-term objective. So providing the best care means providing unbiased care. This involves having meaningful, albeit uncomfortable conversations about bias and fostering a growth mindset among physicians. Encouraging language that promotes growth and celebrates successes is more effective than punitive language. So bias mitigation should be seen as a part of providing necessary patient care. We also need to consider the political and socio-political impacts of bias and efforts to mitigate it, as we heard from discussions in the breakout sessions yesterday. Also, biophysical factors such as the higher incidence of asthma in children from polluted areas should be considered in the context of bias. Language surrounding diversity, equity, and inclusion and implicit bias should be inclusive and adaptable, especially in regions where DEI efforts are threatened, to ensure critical issues are being addressed without penalty. So what are the gaps? We identified key gaps in our understanding and intervention strategies to reduce bias and improve outcomes. While we know that bias exists, lack of clarity on which interventions are most effective persists. For example, should we study the specific physiology of race-related stress and how it differs from normal stress? How do we measure and understand these differences? Another significant gap is the need for shared language and a framework related to bias specifically, especially as we navigate the varied social, political, and legal contexts across different communities and jurisdictions. This shared language could greatly benefit researchers, particularly those who are in their early careers or from traditionally undersourced institutions with limited NIH funding. Clear and consistent language properly communicated and understood throughout the research community can help researchers develop strong grant applications and improve overall research quality. For opportunities, there are several opportunities that will address and improve outcomes based on biases. So first, we can implement micro-level practice and small, digestible skill-building activities that include simulations. We also need more research to understand what clients and patients want to receive in their care. NIH, as our presenters and discussants informed and suggested, should fund intervention studies on implicit bias that go beyond identification and intervention, including research on improving patient outcomes through combined training and systemic changes. Full NIH participation is necessary rather than funneling everything through NIMHD alone. Health systems should invest in addressing bias and discrimination with the same urgency as they invest in preventing adverse events. A multi-level, multi-domain approach is essential considering the interpersonal relationships, identities, and intersectionalities, and systemic factors. This approach could benefit from cross-disciplinary and regional collaborations, as well as community partnerships and engagement. Diverse research teams representing a range of identities, ideas, experiences, and disciplines are crucial. And lastly, more research is needed to better understand how implicit bias impacts patient health outcomes, particularly AI, artificial intelligence, and data science offer opportunities for objective analysis of patient-provider interactions, potentially providing real-time feedback to improve care. So this is the summary of day 2. So shortly, we will have our first flash talk session, followed by the third thematic session of methods and tools to measure interpersonal biases in relation to health. We will then have our second flash talk session that will then lead into the fourth thematic session, evidence-based interventions to mitigate the influence of interpersonal biases on health. Then we will conclude and wrap up. So keeping in mind the overarching questions of this workshop as you present are, what are the most important research questions on interpersonal biases in relation to health disparities that must be answered to expand our understanding? What are the challenges for scientific advancement in the field? What are the opportunities? And what are the most critical gaps in our current understanding of how biases affect health? And how can future research address these gaps? Just to remind everyone of some housekeeping instructions, please maintain your time limits. We will play a chime at 1 minute to warn you that within 1 minute, the time is up, and then right at the time allotted for your presentation. Please mute your audio and video and turn them on only when speaking. We want to minimize background noises. For any technical issues, please contact Mr. Mark Gifford or Juan Romero. And that concludes my remarks today. I will welcome Dr. Karen Marie McNamara to lead us into the first thematic session.
Thanks so much, Carlos. And good afternoon, everyone. I'm glad you joined again today. My name is Dr. Karen Marie McNamara, and I am a program director in the Division of Extramural Science Programs at the National Institute of Nursing Research. And I will be moderating this first Flash Talk session today. Each of the speakers will have 5 minutes to present, and if there is time, we will pose one question after each speaker. And then at the end of the Flash Talks, we will have a short Q&A, time permitting. First, we will hear from Dr. Anesa Flentia from the University of California, San Francisco, who will present on unpacking the biological mechanisms of minority stress among sexual and gender minority individuals. Dr. Flentia.
I think switching to the screen share while you were sharing didn't work. Let me try again. How's that look?
We can see it now. Can you put it in presenter mode? Perfect. Thank you.
Okay, excellent. Yes, so hi there. I'm Anesa Flengie from the University of California, San Francisco, and just want to speak very briefly about what we're doing to try to understand the biological mechanisms of minority stress, specifically among sexual and gender minority individuals. And so briefly, when I began working in sexual and gender minority health around 20 years ago, I was trying to understand what was happening with the health disparities we were seeing among sexual and gender minority individuals. And what I went to look to was the minority stress model as a way to really understand those disparities. And so the minority stress model, it sort of intersects with the discussion of the focus of the workshop that we're in today around interpersonal biases, but it's really about the acute and pervasive stress that sexual and gender minority people experience over time that is over and above regular stress. And it includes, very briefly, things like experiences of prejudice or discrimination, coming to expect prejudice or discrimination, whether or not you've experienced it, and also having a burden of deciding when to be open about or conceal one's minority status. And finally, kind of the internalization of stigma from experiences or the beliefs of others. Now, quite a lot has been done to understand how minority stress is related to mental health disparities, but we're really just beginning to unpack how minority stress is more specifically impacting physical health outcomes. And so one of the first things that we did was to do a systematic review to really look at any study that was out there at the time that was looking at some element of minority stress and tested a relationship between that element of minority stress and some biological outcome. And we found 26 articles at the time we did this review. And what we found was that there was a pretty imperfect rate of replicability of findings, where around just over 40% of analyses detected a relationship between some element of minority stress or bias exposure or other type of bias and a biological outcome. And what we found was when we looked at what minority stress was related to, it was a range of biological outcomes. So things like physical health, incidence of respiratory infection, immune response, HIV-related laboratory outcomes, symptoms, treatment side effects, AIDS mortality, and also changes in cardiovascular function, body mass index, cortisol, and cancer incidence and treatment side effects. So this varies kind of broad range of different outcomes that minority stress was related to, which led me to this question. So if minority stress is related to this range of physical health outcomes, how do we really think about isolating the effects to identify how to interrupt that relationship? And to do this, we really built out this conceptual model here. So in this model, you can see we have minority stress on the left side and all the different components. And if you look to the two right columns, then you're going to see some of the outcomes that we observed in relation to minority stress or kind of the biological functions that are related to those outcomes. You can also see that we have kind of a moderating effect, so coping responses that could change this biological cascade towards these outcomes, and that's one of our moderators there, the second from the left. And the coping could either be something very adaptive, like a coping skill that someone might have, or it could also be something like substance use, both of which would be expected to kind of change this biological cascade. And this study really led me to ask, where in this model should we look first? And we decided to look at the controllers of it all first, really focusing specifically on the mechanisms. And we looked at epigenetic changes and transcriptional regulation. And so here's a couple of examples of studies where we've interrogated this relationship. These were both studies with sexual minority men living with HIV who use stimulants. And on the left here, you can see that we found there's a relationship between sexual minority stress exposure and accelerated epigenetic aging. And on the right, we found a relationship between minority stress and differential gene expression, specifically genes related to things like immune function, inflammation, all of our hypothesized mechanisms. And finally, one additional thing that we did was to develop an intersectional minority stress intervention, so a cognitive behavioral intervention. And we randomized people to this intervention as a way of having coping opportunities. And we looked really specifically for changes in transcriptional regulation and specifically in gene expression. And what we found is that there was a lot of evidence of changes in gene expression, and those genes were related specifically to immune activation in immune processes, suggesting that in fact, we are finding signal where we're looking that there's some alterations related to minority stress exposure in immune processes. And that brings me to the end of my time.
So much, Dr. Flenke. Let's see if there are any questions. So just a reminder for people, if you have questions, to put them in the Q&A box. I don't see any yet. Maybe a 30-second question. Oh, let's see, we do have a question. So what covariates did you control for that? Would you also, for that would also affect the immune system? Sorry, it's,
yeah.
word.
Great question. So it's a little different depending on which study we're talking about, because I presented, there were several there looking at different molecular outcomes. But typically we try to control for things like if we're doing investigation among people living with HIV, we want HIV viral load to be suppressed. We have controlled for things like substance use exposure, stimulant exposure in those models as well. So yeah, it's an important question to consider. It's a little different depending on the specific study.
Thank you. And so the second question, we'll have to save that for the Q&A after. So, but please keep putting your questions in the Q&A box if you can. So thanks again, Dr. Flenke. So now we will hear from Dr. Tiffany Green from the University of Wisconsin-Madison, who will present on innovative methods for understanding the impacts of discrimination on reproductive health. Dr. Green, please go ahead and share your screen.
Can you hear me now?
Yes, we can.
Okay, I was really talking to myself. Okay, sorry about that. So really, I'll just back a little bit. Really, this work is really thinking about how discrimination shapes people's choices about and their experiences of reproductive health care more broadly. And we do that in form of the Reproductive Health Experiences and Access Survey, aka RHEA. And it's a collaborative between the Urban Institute, us at UW-Madison, and Sister Song. All opinions, of course, are my own. And this is a large study that documents the impacts of post-Dobbs policies. We hope to survey over 45,000 respondents. Knock on wood, we will be fielding at the end of the month, so we don't have data to report just yet. The first thing we focus on in RIA is the experiences of Black people, who are about 16% of the population, the repro age population assigned female at birth. They're more likely to live in states that experience abortion bans, and we do targeted oversampling so that we can understand the experiences of the population. One of the large questions that we have in front of us, we'll flip ahead there, is that Black people are more likely to attempt self-managed abortion, that is abortion outside of formal healthcare systems. But what explains that? We haven't been able to fully explain that with standard covariates like education and income and so forth. One of the things that we think a lot about is the fact that non-Hispanic Black women are most likely to report discrimination in formal healthcare settings. So as you can see here in a recent Kaiser survey, that about 21% of the non-Hispanic Black women in the survey reported receiving discrimination relative to about 3% of non-Hispanic white women. But the problem is that these kinds of questions only get at people who are already in care, rather than those who may be avoiding care because of discrimination. And so in RIA, we ask not just about your experiences of healthcare, but whether you are avoiding healthcare because of your experiences of discrimination. In this case, we ask about race, but we also ask about a range of other things, including disability, gender identity, and so forth and so on. And we hope to be able to see whether anticipatory discrimination is linked to people's experiences of abortion care and wanting to go outside of formal healthcare systems, which we don't capture in our regular data. A second emphasis of the RIA survey is on understanding the experiences of disabled populations. So estimates vary, but we know about 12 to 18% of the population assigned female at birth and is of reproductive age are disabled. And we include expanded measures of disability so we can understand their experiences a little bit better. But two questions that are in the literature that I think are relevant to what we are talking about here today is that disabled people are less likely to use long-acting reversible contraception, i.e. IUDs, for example, and disabled people are more likely to have permanent contraception or sterilization relative to non-disabled people. What does this have to do with discrimination? Well, there is a very, very long history in the United States of eugenics and coercion when it comes to disabled people, Black people, and other people that are not cisgender white women. So how do we address that in a survey? First, we ask people, are you using the contraception that you actually want? And we try to determine whether there's a gap between the contraception people want and the contraception that people are actually using. Where does discrimination come in? We ask about people's prior experiences of discrimination. That is, that gap between the contraception that people want and that they're using, is it explained or associated in part with experiences of discrimination? And more important, we need to understand what the mechanisms are. And so we do that by adding a new set of questions about contraceptive coercion. That is, are people reporting that their providers may have influenced them one way or another to use contraception that they didn't necessarily want? For example, did you feel like you had to use this kind of birth control? Did they not give you the birth control that they wanted, for example? And then finally, we ask about contraceptive regret. So we see post-Dobbs that there has been a spike in people assigned female at birth getting permanent contraception, for example, tubal ligation. So we ask about whether people are getting this, and we link it back potentially to discrimination to see if discrimination is playing a role in the patterns of contraceptive coercion that are so common that we see in the news. But in this survey, we are trying to put some boundaries on that and trying to estimate prevalence at the population level. And with that, I will end. I think I am just on time.
Okay, thank you so much, Dr. Green. So there are a few questions. We'll just ask one now. A question is, do you also ask about body weight as a source of stigma for those in larger bodies?
Absolutely. We do.
Okay, great. So we will, if we have time, we will follow up with more questions at the end. Thank you again. Now we will hear from Dr. Paige Lloyd from the University of Denver, who will present on the role of race, gender, and class-based stereotypes in pain perception and implications for equitable pain care. Dr. Lloyd, if you could just, there you go, and make sure you are unmuted. Thank you. Go ahead.
Great, thank you. So I will start by noting that there's ample evidence indicating that people of color, women, people experiencing poverty are receiving less aggressive and less effective pain treatment. And multidisciplinary scientists, many of whom have spoken at this workshop, have identified a number of contributors to these disparities, including both structural and interpersonal mechanisms. In my talk today, I'm going to focus on the role of stereotypes, which might be endorsed by individual clinicians, but are also communicated and maintained by health systems. So I'm quickly going to present some foundational work in this area and some recent contributions from my lab. And then I'm going to introduce an ongoing grant that seeks to translate some of our lab-based work into more realistic healthcare contexts. So there are a number of cognitions that bias pain care. In my talk, I'm highlighting beliefs about sensitivity, emotionality, and trustworthiness. And I'm focusing on these cognitions with respect to their role in pain judgments by race, socioeconomic status, and gender. And so turning first to sensitivity, past work indicates a bias whereby lay participants and clinicians alike evaluate Black individuals as less sensitive to pain than white individuals. And these racial biases and sensitivity are also linked with clinical decision-making. So in work led by graduate student Kevin Summers, we demonstrated that similar pain sensitivity biases emerge in judgments of young Black children and among individuals relatively lower in socioeconomic status. Each of these plots depicts one example study, and below each graph are the total number of studies in the respective line and average effect size. So across 21 of the 22 samples, we observed significant effects whereby Black children and low SES children and adults are rated as less sensitive to pain than their white and high SES counterparts. These effects emerged among lay participants, clinicians, and educators and predicted hypothetical pain treatment recommendations. And before I move to the next line, I just want to note that this stereotype is inaccurate. So in other work from our lab, where we're collecting pain threshold and pain tolerance metrics, we find that if anything, Black individuals and relatively low SES individuals demonstrate more, not less sensitivity to pain. And so the next line of work, we focus on emotionality and trustworthiness judgments. And these are theorized to play a role in pain biases across gender. So work led by graduate student Gina Paganini tested whether perceivers expect women to exaggerate their pain more so than men. So participants judged images of men and women and estimated how much pain they would feel versus claim following a series of painful injuries. Participants tended to evaluate women as claiming more pain than they would feel, but men as feeling more pain than they would claim. And this effect was predicted by participants' own endorsement of gender stereotypes about emotionality. We examined whether these effects emerged across men and women of various racial identities, and we observed this pattern across all racial groups assessed, but it was most pronounced in judgments of Black and Latino women, suggesting greater potential for bias at these intersections of race and gender. And one limitation I want to note of this work, as well as the broader social, psychological, and health sciences literature, is a lack of attention to gender diverse folks. So we're seeking to extend this framework by examining cultural stereotypes of trans men, trans women, and non-binary individuals. And so when we looked at a sample of judgments of these folks across trust and emotionality, we found that gender diverse individuals in our sample were rated more negatively than cis men and cis women. So if these stereotypes are thought to undermine equity in pain care across cis men and cis women, they may be even more detrimental to the quality of care for gender diverse individuals. So finally, I want to talk about an ongoing study. Most of the research that I presented above focuses on lab-based studies and hypothetical pain care, which might lack some realism or similarities to the complexity of actual healthcare encounters. So in an attempt to grow our lab's contributions to pain science, we're currently conducting a standardized patient study where we'll examine race and gender biases in pain treatment and the psychological mechanisms that we theorize could underlie such biases. So in this work, we're recruiting medical students from the University of Colorado Anschutz who are completing their clinical rotations. And medical students are recruited to engage in a simulated emergency visit with standardized patients who vary in race and gender. So we have Black, white, and multiracial Black, white, men and women as standardized patients. We're audio and video recording the interactions between participants and standardized patients and assessing participants' medical decision-making, so like whether they order x-rays and what pain treatment plan they offer. And we're measuring individual differences in our participants, in particular, their trust in their patient and their beliefs about their patient's pain sensitivity or pain exaggeration. And we aim to test whether differences in trust, emotion, or sensitivity beliefs might emerge by patient race or gender, and whether these beliefs predict biases in treatment decisions or quality of those interactions with the standardized patients. So with that, I'd just like to thank my mentorship team and NIMHD who are supporting this ongoing work. And I'll wrap up my talk there and thank my collaborators and of course our organizers for giving me this opportunity to share.
Thank you so much, Dr. Lloyd. Let's see if anyone has a question. I don't see a question, and let's see, there's one question here, a short one. Is the study blinded to the students?
Really good question, thank you. So the students don't know that the study is focused on race and gender, although of course they can perceive social identities, or they may perceive social identities from the standardized patient that they're engaging with. But their understanding is that the study is about how to deliver an ankle injury exam. And so they actually get some prep work where they learn about ankle injuries beforehand, and then they come and do an ankle exam and then come up with a treatment plan and interact with that standardized patient.
Great. So other questions we'll have to save for the end, or you can respond to them. So thanks again, Dr. Lloyd. Now we will hear from Dr. Peter Mende-Sidlecki from the University of Delaware, who will present on perceptual contributions to racial bias in pain care.
All right, and can you all see my slides?
Yes, and we can hear you.
Great. So a huge thank you to the organizers for this workshop. I'm really honored to share my work alongside this phenomenal slate of talks. So there are pervasive racial disparities in pain care, which, though they extend across minoritized and marginalized groups, are particularly well documented within Black individuals. Relative to white patients, Black patients are less likely to receive pain medication overall, less likely to receive opioids for severe pain, and when they do, they receive lower doses. These biases exist for virtually every type of pain, from the emergency room to palliative care, and they're conserved when controlling for SES, insurance, and pain self-report. Now, given the breadth and depth of these disparities, we must take a multi-pronged approach. So, for example, some of the work, including that which you just heard about, explores the roles of stereotypes, for example, related to hardship, status, substance abuse, as well as false beliefs about biological differences between Black and white people. Other work has identified implicit bias, bias in detecting pain authenticity, and intergroup empathy bias as key factors to consider. And clearly, these gaps are also supported by overarching structural factors and historical legacies of racism that influence quality of and access to care. But what about perception? Pain is a social signal that can be communicated through facial expressions we perceive and interpret through our visual systems. And social perception research tells us those perceptual mechanisms are not fixed. They're influenced by group membership, race, marginalization, and minoritization, leading to phenomena like the cross-race effect and perceptual dehumanization. So might this constellation of bias relevant to pain be so insidious that it manifests at the level of basic perception? If so, might perceivers have more stringent thresholds for seeing pain on Black versus white faces, with consequences for gaps in treatment? And my work tests that question. We show participants Black and white targets in varying degrees of simulated pain, one at a time. They rate these targets' pain experience, and we use perceptual psychophysics techniques to calculate their thresholds for seeing pain within each race. Indeed, white participants typically have higher thresholds for seeing pain on Black versus white faces. So in this study, for example, Black targets had to express 15% more pain than white targets to be perceived as actually being in pain. Notably, when we equate faces on low-level features like tone, contrast, and luminance, we still see the same robust perceptual bias. Similarly, when we use computer-generated models of pain and put them on structurally identical Black and white faces, white participants still show biased pain perception, even for identically intense pain expressions. Follow-up work shows that this anti-Black pain perception bias is considerably larger than corresponding gaps in seeing anger, happiness, or fear. It's magnified for ambiguous expressions of pain and operates with relative speed and spontaneity. It generalizes across target age. It's somewhat blunted by heavier weight within male targets, but not within female targets. And it's magnified by visual cues to racial prototypicality. Collapsing meta-analytically across this work, we robustly confirm this perceptual bias across 6,000 plus participants. And in a separate treatment task, these same participants prescribed less hypothetical treatment to Black versus white targets. Critically, This perceptual bias also mediated the influence of race on treatment. Participants recommended less pain reliever to Black targets to the extent that they saw their pain less readily, even when accounting for explicit prejudice and endorsements of stereotypes about things like strength and status. Notably, this bias isn't specific to just white perceivers. It generalizes across perceiver race and ethnicity. Asian, Latinx, and Black perceivers all show similar tendencies to underperceive and undertreat Black relative to white pain. This bias was also consistent across various tasks, stimulus, and sample characteristics, for example, online versus lab-based student samples, and correlated positively with blatant dehumanization of and reduced intergroup contact with Black people. Now, taken together, I think that's a strong case for focusing on perceptual contributions to gaps in pain care. That said, the majority of the previous participants were not providers. The one thing I haven't shown you yet is that this bias persists despite healthcare training and experience. So in most of those 40 studies in that recent meta-analysis, we asked participants to state if they have any medical training or experience, if so, how much, and what role did they serve in. From there, we identified 135 individuals with training in a healthcare relevant field and direct experience with patient care, the majority of whom were nurses, EMTs, or paramedics, or nursing students. And indeed, in these individuals working in or training in a healthcare field, both bias and pain perception and treatment were still observed. And most importantly, perceptual bias continued to predict hypothetical treatment bias. So despite all that training, all that care experience, all the diversity modules these folks likely completed, they still show gaps in the perception and hypothetical treatment of pain in this experimental context. Of course, the next step will be to examine how this perceptual bias translates to gaps in real-world pain care decisions, which we'll be able to test as part of the NINR-funded progress study that Dr. Nao Hagiwara and I are currently conducting. So with that, I'd like to thank my students, some of whom I highlighted during the talk, my funders, my collaborators, and of course you for your kind and patient attention.
Thanks so much, Dr. Mende-Sadecki. Let's see if there are any questions. So do you think perceptual bias, I think it can be corrected based on your work?
I think that's a really important question. So we've done a fair amount of initial intervention testing, focusing on things like, things as basic as directing people's gaze to more diagnostic pain-related features of the face, also more sort of top-down individuation-based approaches. Individuation seems to lower people's thresholds for seeing pain overall, but it doesn't reduce bias necessarily. So I think a lot of these approaches sort of indiscriminately applied don't have as much potential value as they would if they were targeted specifically at the folks who need it the most.
Thanks for answering that. And now we will move on to our last speaker in the Flash Talk, Dr. Idan Shalev from Pennsylvania State University will present on the role of interpersonal biases in systemic dysfunction and biological aging. Dr. Shalev. Okay, we can see your slides. If you can just, there we go, and make sure you're unmuted. Thank you.
Yep. Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. So I just wanted to start by thanking the organizers for the invitation to participate in this interesting workshop. So I'm excited to be here and to share with you some insights in relation to interpersonal biases in relation to systemic dysfunction and biological aging. And although the title indicates interpersonal biases related research, we focus our work broadly on biological mechanisms in relation to early life adversity. So I will try to link this line of work to the topic of this workshop and provide some context for future research. So with that, I want to start off with the big question that we focus on in my lab, which is how early life adversity gets under the skin to generate variability in health and aging. And then two important questions here. First, how do we link early life processes with health and aging that is observed decades later? And second, why should we even care about aging in early life? Is it really aging? Is it development? Does it matter? So I will try to answer some of those questions. This is the conceptual framework that we use in the lab. So as changes in biological aging are thought to be mediated by an accumulation of molecular and cellular changes over time, we consider these moment-by-moment variations both at the phenotypic level using ecological monitor assessments and daily diary, as well as dynamic changes at the cellular level using experimental designs and gene expression measures and inflammation. These moment-by-moment changes can compound to impact health and aging years later to generate variability in systemic dysfunction and aging. And to that end, we also measure multiple indices of biological aging. So our research also considered this lifespan perspective, including prenatal assessments and intergenerational transmission to offspring. But here again, I want to focus on development and early life processes. So to illustrate the second point of why should we even care about aging in early life, this is a recent meta-analysis focusing on telomeres and chronological age across the lifespan. This is one of the main figures from this large-scale meta-analysis using time-varying effect modeling to illustrate the strength of the corrected correlation between telomeres and age on the y-axis, plotted against chronological age on the x. So in other words, what I wanted to highlight here is the strength of the correlation earlier in life. So not only the children are aging, biologically speaking, they're actually aging at faster rates than adults. And this corresponds to known trends of telomere shortening due to increased growth rate and cell division, but we also know this is a very sensitive developmental period where adversity can get under the skin to generate all of these adverse health outcomes later in life. So these are some of the research questions that we and many others are asking. What are the biological mechanisms underlying the stress-disease relation, or how stress gets under the skin? But I can also replace that if we think about interpersonal biases as a stressor. What are the biological mechanisms underlying that relationship? Secondly, how do these mechanisms interact with aging process? And again, to that end, we measure multiple indices of biological aging, including telomeres. And lastly, and importantly, what factors promote successful adaptation and or resiliency to adversity? This is in terms of lifespan influences. So interpersonal biases can be studied in the context of telomeres, and I'm just giving an example of telomeres here across the lifespan. So this is a figure from a review paper that was published more than 10 years ago, but still relevant nowadays to think about conceptually about lifespan influences. So we showed that there is impact of prenatal adversity, childhood trauma, adult mental disorders, age-related diseases, all can impact the rate of biological or cellular age over time. And we also highlight some of the healthy lifestyle behaviors at the top that can help to mitigate the impact of adversity on biological aging. So again, if we think about interpersonal biases that can be studied in that context across the lifespan. And in terms of mechanisms, we are really interested in understanding the potential mechanisms. Just again, given the example here of early life adversity, and we know it's a risk factor for a host of age-related diseases. If we think about telomeres, there are biological aging measures that can potentially function as a mediator. The question is about the causality, how stress is actually causing telomeres to erode and how short telomeres is actually causing increased risk for age-related diseases. It's obviously a very complicated process. Some folks have talked about it yesterday. Some biochemical stressors in the cell, epigenetic regulation, the stress response system, inflammation and oxidative stress are very important in relation to telomeres, mitochondrial regulation, as well as this triangle of thoughts, behaviors, and emotion. They're all important and interact in order to understand the underlying mechanism. So I'm just on time, and I'll finish here. I'll be happy to take any questions.
Thank you so much, Dr. Shala. So let's see if we have any questions. So I will start with this question. I'll open it up to you, Dr. Shala, and then if any other of the presenters want to answer it, they're welcome to after you. So, so what do you think are the most critical gaps in our current understanding of how interpersonal bias exposure influences health outcomes, and how can future research address these gaps?
Yeah, this is an excellent question that will probably involve some discussion with other participants. I think, first of all, measurements. How do we even measure that? Conceptualizing interpersonal bias. This is not my area of expertise. I'm focusing more broadly on early life adversity, child maltreatment. But even within that field, there is a lot of different types of questions about different types of abuse and age of onset and chronicity, perception of the stress. So it's a complicated process. In terms of biological mechanisms, I think we need to integrate a lot of different systems. to use maybe multi-omic approaches, to use some computational modeling to try and understand the biological mechanisms. We need longitudinal designs to be able to track, trajectories over time in individuals. And I think what I tried to highlight in my talk really try to focus also on processes that are happening earlier in life.
Thank you for that. And I wanted to open it up, as you said, Dr. Shalov, this is really a broader question. If other panelists, if you have insights in terms of what you think are some of the most critical gaps for understanding of how interpersonal bias exposure influences health outcomes, and what you see as the ways that future research can address these gaps. So we'll open it up to the whole panel. We have a few minutes if anyone else wants to chime in.
I can speak a little bit to, I think one of the issues that we have is around actionable solutions. I think, a lot of what we see in terms of what bias does are things that we would expect if we've been immersed in this. And I think we have less tools to create action, which it can be frustrating, but I think is a direction we need to sort out.
I think I completely agree with that. I'd also add that I think that there's often a focus on carving out a space for a particular factor or confirming that a particular factor has some outcome or some consequence, controlling for other already identified factors, rather than examining how these multiple factors interact with each other, compound each other, exacerbate each other. And, obviously there are reasons from practicality standpoints that we can't dump everything into the study, but I think that ultimately leads to some narrow views of the relationships at play here.
So I think I'm sorry.
No, please go ahead, Dr.
So I think one of the things, I guess, that I see as someone who does a lot of birth equity related research is a need to bridge the experimental evidence in a clinical world. I think that it's sort of broadly thought that discrimination from providers is what is driving racial inequities in pregnancy related morbidity and mortality. And I don't think we have sufficient evidence to make that link. I think it's very clear that providers, clinical providers more broadly have biases, both implicit and explicit, but I think we need a lot more clarity about the, whether and to what extent that is driving racial inequities in birth outcomes and health outcomes among birthing people. And those are different questions. And I think we have made policies and we have put in interventions that literally have not addressed the underlying mechanisms or established whether those kinds of interventions are needed. So I think that is, one of the key unanswered questions that remains unanswered, unfortunately.
So we have 1 minute if any other of the panelists want to answer that question.
I'm happy to just chime in and connect it back to yesterday's session, where folks were talking about the importance too of like context, and then how much the context can create also ambiguity in those interactions, and how that is like a rife opportunity for biases, if they are playing a role in these clinical decision making, to seep in. And then also how I think folks were kind of circulating yesterday on how important, like Dr. Green is saying, these like structural and policy level and in the healthcare system, what is being like perpetuated through those policies. So I agree with that, like kind of us pulling together the interpersonal and the structural is going to be, I think, really important for our field moving forward.
Great, thank you. So I just want to thank all of the presenters again for such wonderful flash talks. You were so concise and shared so much in this short amount of time. And thank you again to all the participants for such insightful questions. So if we're able to give you all a virtual round of applause to all of our flash speakers, and sorry we didn't have more time for Q&A. So the time is almost, 1:19, it's about to flip to 1:20. So next we will have a short break and we will return at 1:25 for our next session. And this next session will be led by Dr. Barksdale. So thanks again, everyone, and see you in a few minutes.
Okay. Welcome back. Hopefully everyone is back from break. We're going to get started again. My name is Crystal Barksdale, and I am a program director in the Division of Community Health and Population Science at the National Institute on Minority Health and Health Disparities, or NIMHD. And I am pleased to be moderating this session on methods and tools to measure interpersonal biases in relation to health. I am very excited to introduce our first speaker of this session, Dr. Jordan Axt, who is an assistant professor of psychology at McGill University, as well as the director of data and methodology at Project Implicit. Dr. Axt will be presenting on understanding variation and predictive validity across measures of implicit associations. Dr. Axt, I invite you to turn on your camera and turn the virtual floor over to you.
Okay, thank you very much, Dr. Barksdale. I'll just share my screen here. Okay, so my talk today, relative to the prior very interesting sessions, is going to be a little bit more on the practical side of things, how the existing tools that we have to measure something like implicit bias, how do they function relative to each other, and how might we be able to use them productively in your own research. So I'll be walking you through a paper that came out last year, which is open access for anyone who would like to read it. And I'll also share some resources embedded within that paper about how to maybe take some of the approaches that I'm going to outline here and apply it to your own work. But really the main question of interest in this research was looking at how oftentimes measures of implicit associations, or what many people might call implicit bias, they're used to predict meaningful outcomes. So, for example, something like a patient outcome or a doctor, or the strength of a doctor-patient interaction, something like that. Researchers are interested in what predicts variation in these types of outcomes, and they use measures of implicit associations to see if they can explain some of that variance. One common goal of these measures of implicit associations is to show that they have some sort of predictive power above and beyond self-report, right? Do people's implicit racial attitudes suggest something about these outcomes above and beyond just self-reported racial attitudes, explicit racial attitudes? And in these cases where we can statistically show that above and beyond what people are saying explicitly, there is something to be said from these implicit measures, that's what we would call incremental predictive validity. Predictive validity, predicting this outcome above and beyond people's self-reported beliefs or attitudes or stereotypes. However, there are kind of common issues with many of the ways that people go about testing for incremental predictive validity in the literature. I think the most common one, and one I was certainly taught and have used in my own research previously, is just using linear regression. So taking an outcome and predicting it by a participant's score on their self-reported attitudes and on their implicit attitudes. But the problem is that this type of approach, linear regression, doesn't do a great job of accounting for measurement error. All measures are imperfect. They don't do a perfect job of tapping into our larger construct. And so there's the risk, especially when the two constructs that we're interested in, for example, explicit and implicit racial attitudes, when they are measured with moderate reliability and they're correlated with each other, there's this worry of an inflated type 1 error rate, such that, for example, one construct, implicit racial attitudes, is capitalizing on the measurement lack of reliability in explicit attitudes. And it's really only because it's tapping into this imperfect measurement of the construct that it's showing evidence for incremental predictive validity. It's not actually there. It's only there because of some sort of measurement flaw that we're not really properly accounting for statistically. Unfortunately, we can do that by using things like structural equation modeling that actually control for measurement error. So you can reduce this risk of false positives, of falsely concluding that your implicit association measure is actually predicting these outcomes above and beyond self-report. So I'll walk you through kind of two large-scale investigations that we've done to look at this issue. What is the rate of incremental predictive validity from these two analysis approaches? This is all work done on Project Implicit. So this is all research done on, volunteers completing these studies online. In our first investigation, we were focused only on the implicit association test, the most common measure of racial implicit associations, excuse me. And in this version, across 15,000 participants, we randomly assigned them to one of 10 different kind of intergroup topics. These are the ones that are the most common on the Project Implicit demonstration websites. And then within each one of these topics, they completed measures of implicit associations, self-reported associations, as well as for each one, 25 different outcome measures. So 5 different outcome measures for each one of these kind of larger groups of outcomes. So beliefs related to that domain, or contact with stigmatized groups related to that domain, relevant policy beliefs, predicted reactions, how would you behave if you had this type of interaction with someone, and motivations to control prejudice. So we tried to give ourselves a decent spread here, although granted they're all self-reported. And then we tested for across each one of these altogether 250 outcomes. How does this outcome, what is the evidence of incremental predictive validity when we use just linear regression, predicting that outcome from people's explicit attitude scores and the IIT, and from structural equation modeling, where we're building a construct such that we have an explicit attitudes construct, an implicit attitudes construct, and we're using them to jointly predict this outcome. How do things look? Well, they look honestly pretty similar. This is a correlation. This is a plotting for each one of our outcome measures. Just what is the beta coefficient for when it's linear regression versus SEM? They largely seem to be telling the same story. And indeed, they agreed 91% of the time. So there was this risk here that potentially all of the prior studies using the IIT and linear regression were just capitalizing on this risk of type 1 error by not properly accounting for measurement variance. But that doesn't really seem to be the case, so that we all kind of breathed a sigh of relief there. But this is just one measure. There's many different measures for measuring these types of implicit associations, and this was really the goal of the follow-up study. So we had a very similar design in terms of the domains the topics that we used and the outcomes that we measured. But now, rather than just focusing on the IIT in this follow-up paper, we had randomly assigned people to complete an IIT, a single category IIT. So for example, in the case about race, only focusing on associations towards Black people versus in the IIT, associations towards Black relative to white people. An evaluative priming measure where people are tasked with identifying whether a word is positive or negative, and before that word is presented, very quickly a face, or in the case of race, of a Black or a white person is shown to see how the presence of a Black or white face facilitates the identification of a positive or negative word. Or this sorted paired features task. It's not as popular within the implicit cognition literature, but it's a version of the IIT that tries to get around an order effect. So basically, participants are shown pairs of stimuli at a time, and they have to decide which pair is being presented to them. So this is a positive word and a Black face. So they would present down here, key N. So now we can compare across these different implicit association measures to see how well they're doing in various outcomes. One outcome you might be interested in is just what is the overall effect that we get? What is the size of the effect seen in this task? Meaning basically, is it showing evidence of implicit racial bias, for example? And we can do that across all 4 of our measures here. And I'm just plotting across each one of the topics that we studied, the largest effect that was produced. This one here is the IIT produced the largest effect just in terms of Cohen's D for more positive associations towards younger versus older people. And across all of our domains, there's a pretty consistent story that the IIT did the best at just producing an effect on average. The evaluative priming had the weakest effect across them. But what about for this main measure of reliability or predictive validity? We can also look at test-retest reliability across our sample. Again, some measures did comparatively better than others. Notably, evaluative priming did not do particularly well when people did the same task 2 times in a row. Okay, but getting to our test of predictive validity, one question you might have is just what is the overall rate at which these tasks just simply predicted the outcome of interest that we had here? So ignoring self-reported attitudes or stereotypes right now. So how did it fare in terms of just predicting our outcome of interest? You get some surprising variability here, right? So for example, the single category IIT would lead you to suggest that yes, this measure that's tapping into implicit associations is predicting the outcome 3/4 of the time, where it's the opposite for evaluative priming. We only found that evidence 1/4 of the time. Now, what about incremental predictive validity? Now, statistically accounting for people's self-reported attitudes, again, we get a wide degree of spread here, such that for some cases, it's only 7% of the time where we'd find evidence of incremental predictive validity, sometimes as high as 63% of the time. This to us was a little bit surprising because these measures tend to be treated a little bit interchangeably in the literature, but we're showing real variation across them in terms of how well they're doing at predicting these outcomes of interest. So the overall rate of agreement, where if you just chose any two measures and said, would they agree in their assessment about whether these measures predict this outcome? Only 57%, not a very high rate of agreement across these four measures that all largely shared the same goal of tapping into a single construct. What about the rate to which they agreed with the IAT, our most common implicit association measure? Again, the rates were not particularly high. None of them agreed with the IAT more than 2/3 of the time. So really, it suggests that the conclusions you would get as a researcher about whether there is evidence of incremental predictive validity would be a lot more dependent than we might originally think, based on the specific measure that you chose. So we can also see that this plot here between linear regression and structural equation modeling was very similar for all of them. They all came to the similar conclusion about the strong relationship that generally there's not this huge risk of type 1 error from just relying on linear regression. But to think more broadly about some potential conclusions here, these measures of implicit association should not be considered easily interchangeable. We saw that the rate at which they had incremental predictive validity, the rate at which they agreed with each other, was really not shared strongly across these measures. And so researchers might have to put some more thought into which measure they're most likely to use based on their research goals. Some measures, for example, the IAT, did a great job of maximizing the chance of finding an association. So if you just want to identify an association that you're interested in studying, the IAT might be the most appropriate route. But instead, if you're interested in maximizing your chances of looking into predictive validity, then you might need to use other measures such as the single category IAT. My best explanation for why this might be the case, why did the single category IAT do so well? Well, for one, we built our single category IAT to only focus on associations towards stigmatized groups. And so we didn't have anything about associations towards majority groups there. And it might be the case that when you have these types of associations towards majority groups, that they're this kind of diluting factor, that they're bringing information that's not really all that relevant to understanding your outcome of interest. Oftentimes, the outcomes we focus on are outcomes that are centered only on these stigmatized groups. So removing the associations towards these non-stigmatized majority dominant groups might do a better job of, might introduce information that's not relevant for understanding prediction. So with that, I just want to point you to the resources that we've made available to anyone looking to build off of this work. So you can come to the OSF page outlined in this paper, and you can adapt scripts and for conducting these analyses yourselves. And I just want to thank my collaborators for their work and help on this project. And so with that, I will stop my share. I look forward to answering any questions.
Great. Thank you so much, Dr. Axt. Okay. Next, we have up Dr. Nancy Krieger, who is the professor of social epidemiology and American Cancer Society clinical research professor at the Harvard T.H. Chan School of Public Health and the director of the HSPH interdisciplinary concentration on women, gender, and health. She's joined by Nikisha Johnson, who's a statistical analyst at the Harvard T.H. Chan School of Public Health in the Department of Social and Behavioral Sciences, who's focused on modeling health outcomes and characterizing health inequities, and Dr. Sari Reisner, who's a tenured associate professor in the Department of Epidemiology at University of Michigan School of Public Health, and who's also a faculty affiliate in the Center of Social Epidemiology and Population Health and at the Eisenberg Family Depression Center. They will be speaking and presenting on a talk entitled Advancing Novel Methods to Measure and Analyze Multiple Types of Discrimination for Population Health Research, the Life and Health Study. Drs. Krieger, Johnson, and Reiser, the floor is yours.
Thank you very much. So I'm stated Professor Nancy Krieger. I'm based at the Harvard T.H. Chan School of Public Health. And on behalf of our study team, we're delighted to share with you some of our work in progress for our study named on this slide, which we otherwise call the Life and Health Study. Our team members are variously based at my school, within our 3 community health center study partners, and also in Italy. In our brief 12 minutes, I will introduce our study, then our data analyst, Nikesha Johnson, will describe our study participants, and our co-investigator, Dr. Sari Reisner, will present key preliminary findings, followed by my closing remarks. So in brief, our study was motivated by concerns about the continued reliance on self-report measures and research examining the health impacts of exposure to discrimination, often only in relation to one type of discrimination. Building on our prior work showing the value of using both implicit and explicit measures of racial discrimination, using the original and long IAT or implicit association test, we designed this study to use the new brief IAT to enable us to study multiple types of discrimination, specifically racism, sexism, heterosexism, transphobia, ageism, and fat phobia. Our primary health outcomes are psychological distress and sleep disorders. Today, however, for our methodological presentation, we focus on our work in progress regarding the secondary outcome of smoking and vaping, with the objective of the study being to understand interrelationships among the exposure measures and how best to model them in our health analyses. This recruitment material gives you a sense of the spirit of our study and makes clear our ultimate objective, quote, empowering people and communities to live healthy, dignified lives, end quote, which we will achieve in part through our work with the community health centers, which can help turn data into action. First, some background. We did some pilot studies led by our social psychologist co-investigator, Dr. Maddie Marini, who has collaborated with several of the speakers in today's session. In our first pilot study using the Project Implicit platform restricted to US-based and US-born participants, we demonstrated that we could efficiently measure exposures to the multiple types of discrimination, with each brief IAT taking approximately 2 minutes to administer, hence 12 minutes in all. By the way, I did prepare a list of all references, which I gave to the conference organizers, which is my understanding will be shared in the chat, so you have all the references for the material I present. In our second pilot, also using the Project Implicit platform with the same inclusion criteria, we demonstrated that US white, Black, and Hispanic participants respond differently to group-specific racial ethnic categories as compared to the general category of people of color, leading us to use group-specific categories for contrasting the target versus dominant groups. Again, the handout provides the study citations. Nikesha.
I'm now going to provide some background on our study population and some of the recruitment challenges our team faced. To capture a diverse study population with a wide range of experiences, we recruited working age adults from age 25 to 64 years old from 3 partner community health centers based here in Boston, Fenway Health, Mattapan Community Health Center, and Harvard Street Neighborhood Health Center. Our target goal was to enroll at least 350 people per social comparison group. However, due to the COVID-19 pandemic, our survey response rate ended up being lower than anticipated. We intended to recruit or to have a survey response rate of about 80%, but ended up with a response rate of 49%. In our case, we also were recruiting from an underserved patient population who were experiencing the highest burden of COVID-19, in addition to significant economic impacts and socio-political stress. So ultimately, among those who we recruited who met our eligibility criteria, enrolled, and completed study protocol, we ended up with about 699 participants, of whom 88% were recruited via Fenway Health. It is important to note that although all the community health centers provide patient care, regardless of patient insurance status or the ability to pay, the patient populations served are very different demographically. And this is evident when we take a look at select demographics by recruitment site. Fenway participants were predominantly white, non-Hispanic, highly educated LGBTQ men, with over 40% of participants holding a graduate degree. In contrast, Harvard Street and Mattapan participants were predominantly Black, non-Hispanic, straight cisgender women, with the majority having some college or vocational school. This slide is a lot to take in, and I can't explain all of it in detail, but I just want to point out here that for each of the 6 domains of discrimination, our study employed 5 measures of discrimination: 2 implicit, which were assessed using the brief implicit association test, and 3 explicit or self-report. This figure here is displaying density plots, which show a smooth distribution of the scores for each of the discrimination measures by domain and by social comparison group. We've plotted unique curves for each of the social comparison groups, which we have distinguished by color. to compare the difference in score by distribution group. The peaks on these distribution curves represent how concentrated the scores are around those points. And the key take-home message from this figure is that across all the domains, target group members tend to have higher scores compared to dominant group members. And when we look at the distribution for the same construct by measure type, meaning implicit or explicit, it's clear that they're capturing different results, and there's a lot more variability in score when we look at the explicit measures.
As Dr. Krieger stated, we sought to evaluate the interrelationships between implicit and explicit discrimination exposure measures. So for each experiment, racism, sexism, heterosexism, transphobia, ageism, and fat phobia, we assessed associations using correlations with the Spearman-Rho measure. So on this slide, we show results from the racism experience. We know there's a lot of data, so we just want to emphasize the key takeaways while also orienting you to what's on the slide. So in brief, the key takeaways are, firstly, that across experiments, we generally found modest associations between discrimination measures. Secondly, these correlations typically were stronger among those persons who self-reported no exposure to discrimination. And thirdly, these results varied by membership in the target versus the dominant group. So as you can see on this slide, we stratified by membership in target versus dominant group here for racism, people of color compared to white people, and also stratified by explicit discrimination using the experiences of discrimination or EOD scale. To orient you, the left column represents correlations for persons self-identifying as white non-Hispanic, here the dominant group, and the right column displays correlations for participants self-identifying as people of color, the target group. The top two matrices present correlations among those reporting no explicit discrimination, scored 0 on the experiences of discrimination scale, and the bottom two show associations among those reporting experiences of explicit discrimination at a score of 1 or higher. We also include two self-reported scales relevant to the validity of the discrimination measures regarding social desirability and the broader US sociopolitical context. The patterns of correlations are evident but modest, and again, stronger for the target group, and among them, stronger for those not explicitly reporting exposure to racial discrimination. We'd also like to note that although social desirability was not associated with any of the racism metrics, it did exhibit correlations for the target groups for traditional sexism and for cis-sexism. Similarly, while sociopolitical concerns were not associated with any of the racism matrix, we did find evidence of an association between sociopolitical concerns for other types of discrimination. We next sought to evaluate the association of implicit and explicit discrimination exposures with the odds of smoking or vaping. This slide displays parameter estimates, odds ratios, from covariate adjusted models from each experiment with smoking and vaping as the outcome. The red line with the triangles represents the estimate for the target group, and the blue with the circles are odds ratios for the dominant group. Note that for the sexism experiment, there were two target groups, women and non-binary or genderqueer individuals, with men as the dominant group. As you can see, the associations of discrimination exposures with smoking, firstly, varied for implicit and explicit discrimination measures. Second, were heterogeneous across experiments. And third, differed for dominant and target groups. We next took the novel step of conducting a meta-analysis to analyze the results across all 6 types of discrimination while preserving the heterogeneity of results across the experiments. So here we use meta-analysis to analyze the 6 models shown in the prior slide to look at the overall pooled effect of implicit and explicit measures with smoking and vaping. As in the prior slide, the dominant group is represented in blue and the target in red. Of note, the point estimates of the target group effects were in the same direction and had the similar values for the implicit and explicit measures. However, for the dominant group, the implicit and explicit measure yielded different odds ratios of smoking and vaping. Elevated odds for explicit discrimination measures and null odds for the implicit measures. In these models, odds of smoking and vaping were not associated with social desirability, but were elevated among those reporting higher levels of worry about sociopolitical concerns. So in summary, we found, as expected, that first, implicit and explicit discrimination measures yielded distinct but complementary insights about exposure to discrimination. Second, implicit and explicit measures were generally moderately associated with one another, but were more strongly associated with one another for members of target groups and for those reporting no explicit discrimination. Relatedly, social desirability was also different for some target groups, but not for all, but especially for traditional sexism and cis-sexism. Third, there was substantial heterogeneity across the experiments in the association of implicit and explicit discrimination measures. with smoking and vaping, indicating different effects for different types of discrimination, for racism, sexism, heterosexism, transphobia, ageism, and fat phobia. This finding highlights that discrimination experiences are not monolithic, and it is important to examine different types of discrimination. Fourth and finally, the association of implicit and explicit discrimination exposure with smoking and vaping appeared to differ by membership in target and dominant groups. So this finding underscores the importance of examining effect estimates stratified by membership in the target versus dominant group. Additionally, sociopolitical concerns were independently associated with smoking and vaping, highlighting the need to consider the broader context in which discrimination occurs. Our next steps to these analyses will be to test formally for effect modification or moderation in the association of implicit and explicit discrimination measures and smoking and vaping.
In closing, we suggest that our study first provides additional affirmation for the need for empirical health research to include both implicit and explicit measures of exposure to discrimination as expressed by individuals, and demonstrates the practical feasibility of doing this by using the brief IAT plus self-report measures. Second, it provides novel evidence that it's critical to analyze results separately for members of the target versus dominant groups, and that it's useful to make these comparisons across multiple types of discrimination using the novel meta-analysis approach we have employed. And third, it provides suggestive evidence that it's important to include relevant contextual measures, for example, about sociopolitical anxiety. And then in our larger study, new results, we'll be looking at other measures of structural racism, including, for example, exposure to racialized economic segregation at time of birth and at time of the study. We'll be extending this work in our upcoming analyses of our study's primary health outcomes, which are psychological distress and sleep disorders. And we suspect that these outcomes will have somewhat different relationships with implicit and explicit measures as compared to what is seen here for smoking, vaping. So stay tuned. Thank you.
Excellent. Thank you so much, Dr. Krieger, Dr. Reisner, and Ms. Johnson. All right, next we have up Dr. Jan de Houwer. Dr. de Houwer is a full professor at Ghent University in Belgium. Dr. de Houwer's research is related to the manner in which spontaneous or automatic preferences are learned and can be measured. Dr. de Houwer will discuss implicit bias as behavior of individuals and groups. Dr. de Houwer, excuse me, I invite you to turn on your camera and the virtual floor is yours.
Hi, I'm here. Can you hear me?
Yes, we can hear you, but
And
can't
can you
see
see
you.
the slides?
We can see the slides.
Thank you. So thank you for the invitation and the introduction. I'm going to give a bit of a different talk than the previous one, as I'm not going to talk about data, but about concepts and the idea of implicit bias as a behavior of individuals and groups. Yep. I don't see my screen moving, sorry. Okay. Do you see the next slide now?
Yes, we do.
Okay, thank you. So typically, if people think about implicit bias, they think of some kind of latent mental construct. So there is for example, in our memory, an association between, for example, Black people and bad. And this association in our memory produces all kinds of behavior. It can make us not hire a Black person when we want to hire somebody, or we react with negative facial expressions, or all different types of behavior that can be caused by this underlying mental association. And then in order to predict those behaviors, researchers develop measures that kind of tap into this mental construct. And with those measures, we try to predict behavior. So if you think of implicit bias in that way, you see it as a thing, as something you have inside of you that makes you do bad things, and it's implicit without you knowing that it's there and that it's influencing you. And this is quite a disturbing view of a kind of monster in us that makes us do bad things we don't know of and we don't want to do. And this view also is inherently a source of controversy. It has sources of controversy. First, the word bias is often used in a way that it implies inherently a moral wrongdoing. And there's been a lot of discussion about whether all of this implicit bias is normatively or morally wrong or not. It also leads to theoretical debates on the nature of that inner cause. Is it an association? Is it a proposition? And thereby this discussion detracts attention away from what from a pragmatic point of view really matters. And what really matters is what people do, is their behavior. The view also complicates measurement and intervention in the sense that the measures try to capture something that you cannot see. It's in our mental world. We cannot observe our mental world, but we need to find something that is a valid index of that mental world. And that is notoriously difficult to do. Also, the same thing for interventions. It's very difficult to validate that your intervention is changing an underlying latent mental construct. So given these problems, I've proposed another perspective on implicit bias, namely implicit bias as a behavior. And I can illustrate this idea with the following example. Imagine that you're an interviewer and your task is to hire a person or not, and you are interviewing, you have a CV in front of you during the interview. You are interviewing a tense black woman in a room that is ugly and there's bad weather. So basically you are behaving as the interviewer in a situation where there are many features, and each of those features can influence your behavior. They can influence whether or not you will hire a person for a specific job. Now, behavior in its most essential form is basically responding to features in our environment, and all of these features can influence our behavior. We can respond to different features. And in that way, we can make a distinction between explicit responding and implicit responding. Explicit responding would be responding to a feature when the conditions for responding to that feature are optimal. For example, in the example, responses to the CV, that the conditions for that are optimal. You are conscious of the CV, you are conscious of your goal to process the CV. This is your main task. You don't have anything else to do. You simply have to focus on the CV and make your decision. You're aware of this, of your behavior and the relation between the CV and your decision and what you do, and you have taken ample time for it. So it's no surprise that a feature like the CV will influence our decision in this process, will influence whether we will hire or not a person. But our behavior can also be influenced in automatic ways. So implicit responding would be responding to features when conditions for responding to that feature are suboptimal. And in the interview example, we can take the example of skin color. The interviewer probably doesn't have the goal to process skin color or to pay attention to it. The interviewer has other things to do. He's reading the CV and trying to focus on this. He might be even unaware of skin color or the impact of skin color on behavior and has devoted little time for processing skin color. So definitely the conditions for responding to skin color are suboptimal in this interview situation, yet it might still be that skin color influences our responses. And when we see such an impact of features on behavior under suboptimal conditions, we can talk that there is an implicit bias. Our behavior is biased by features in an automatic way. For example, there might be a racial bias in hiring that is unintentional. There could be an impact of skin color on what we decide, but that happens even though we don't have the intention to show this, or even when we don't have time to process skin color or whatever. And then explicit bias would be responding to a feature under optimal conditions. For example, racial bigotry would be explicit bias because you have the intention to respond, for example, to skin color or to gender of a person. You have the intention and the time to do this. So this is the distinction from a behavioral point of view, the distinction between implicit bias and explicit bias. This is, of course, a dimension because the conditions can go from suboptimal to very optimal. This is a dimension. But still, the distinction between implicit and explicit bias remains very important, because the way you respond to a feature could be very different under optimal conditions than under suboptimal conditions. For example, intentionally, you might have the intention not to show negative responses based on skin color, but when you don't have the time to process it, or when you're engaged in other tasks, you might still do it. And in one of my publications, I've made the analogy between implicit and explicit bias with a car, the performance of a car. It's important not only to examine the performance of a car under optimal conditions, when the best possible performance of a car, but also what happens when you put the car under strain, when it's the conditions are suboptimal, when what happens when you put strain on the system. So what are the advantages of this perspective on implicit bias? First, the focus is on the core issue, at least for practitioners, and that is what people do, not what they are, what is inside, but the actual behavior is what matters. It also simplifies and reorients measurement and intervention, because the aim is no longer to capture this hidden thing inside you, but the aim is simply to observe the behavior, to observe the causes of the behavior, and to measure them and to try to change this. So if we go to measurement, for example, one implication of this view is that the IAT is no longer a kind of channel to a hidden entity. It is merely also an example of behavior itself. You are pressing keys, and the pressing of the key can be influenced by features like skin color. So the IAT is not, in that sense, not a measure of something hidden, but it is an instance of behavior itself. It allows you also to treat implicit bias as an important phenomena without engaging in these other debates, without having to take a position about what is this hidden force, whether the behavior is ethical or not, whether it should be legally binding or not. These are all debates that are possible, but you don't have to commit to a position on these debates when you take a behavioral point of view on implicit bias. As a behavioral phenomenon, it's simply the impact of social features on behavior under suboptimal conditions. And by separating the phenomena from all the debates you can have about the phenomena, I think this view promotes communication, cumulative science, and education. Another one point I would like to emphasize in this task, I haven't emphasized it in the paper, is that it also allows us to consider implicit bias at the level of groups. From the perspective that implicit bias is something hidden in your mental system, it's very difficult to think about implicit bias in groups, because logically speaking, I think it doesn't make much sense to say that groups have a mind or that they have a mental system. But groups, they do behave. And for the interest of time, I'm going to skip this one slide and immediately go to the idea of implicit bias in a group. It's not strange to say that there are groups. Any system that consists of multiple individuals can be called a group, like a company, a police unit, a hospital, or a county. And you could also say that groups behave. It's basically what groups do. Like companies, they hire, police units, they make arrests, hospitals make treatments, counties and countries, they give taxes. So groups also do things. And then the question of implicit bias in groups is, what does the group do? Does the behavior of the group depend on social features, and then that would be bias? And does it depend on social features under suboptimal conditions? That would be implicit bias. For example, is the behavior of a group influenced by social features, even when there are no policies for responding in that way? That could be one view on implicit bias by groups. And it's easier, I think, there are advantages of studying implicit bias at the level of groups, because there's, for example, more data available there. It's easier to establish bias. I also think it's easier to implement interventions at the level of group. And as the the talk of, for example, Professor X showed, I think there is more, it's easier to predict bias at group levels than at individual levels. So to conclude, I think individuals and groups respond to social features in the environment, either under suboptimal conditions. These responses can be different from responses under optimal conditions. It is good to raise awareness about this phenomenon, but the phenomenon of implicit bias does not require that you take a position with regard to different other debates. So it's easier, I think, to measure and prevent bias at the group level than at the individual level, and none of this requires a commitment to specific theories or normative claims. That was my presentation.
Great. Thank you so much, Dr. DeHauer. Okay, and for our last speaker for the session, not our discussant, but our last speaker, we have Dr. Michael Brownstein. Dr. Brownstein is a professor and chair of philosophy at John Jay College and the professor of philosophy at the Graduate Center of CUNY. Dr. Brownstein will be presenting a talk entitled "On the Relationship Between Structural Change and Individual Change." Dr. Brownstein, the floor is yours. Virtual floor is yours.
Thank you. You can see my slides okay?
Yes, we can.
Okay, great. Thanks so much. This talk is going to be a little bit different as well from those we've heard before, not data-driven, and also a little bit betwixt and between the themes of the session. So it might belong as much in this one as in the session later today about interventions, but I hope that's okay. So I want to begin with an example of an article from the New York Times from 2022 about the causes of diabetes and how to deal with them. And it's an article discussing researchers who are pushing back against a familiar way of thinking of diabetes as being caused by poor individual decision-making. So the journalist writes, "There is no device, no drug powerful enough to counter the effects of poverty, pollution, stress, a broken food system, cities that are hard to navigate on foot, and inequitable access to healthcare, particularly in minority communities." Quoting Dr. Dean Schillinger, "Our entire society is perfectly designed to create type 2 diabetes, and we have to disrupt that." The sort of view that Dr. Schillinger and others are pushing back against is, I think, perhaps best characterized from another domain, the early days of the environmental movement, when the idea was that a social problem, in this case like pollution, is the sum total of the result of individual decision-making. And the solution is therefore for each of us to take responsibility for the problem, do our part, and therefore solve it. I'm going to call that an individualist ethos, and it's one that I think is characterized back into the context of health problems as having to do with individual frailty. Those sources of individual frailty can be cashed out in lots of different ways. So on the patient side, you might have in mind lifestyle choices or adherence to medical guidelines. On provider sides, you might think of the sorts of biases that people in this session have been talking about. And so the intuitive solution is for individuals to make better choices. There's a whole world of empirical research that proceeds in this vein, some of which most people here are familiar with. The way you might characterize it broadly is by trying to identify antecedents of good individual decision-making by isolating the key variables found within individuals. So those might be just some random examples: motivational conflicts, personality traits, stereotyping or dispositions to stereotype, cognitive distortions. The sort of ideas here are also widely out there in the popular discourse, individualist ideas. I just chose one book at random of many that capture this idea about taking responsibility for social problems and fixing them at the individual level. The sort of pushback that Dr. Schillinger and others are arguing for is, I think, best captured in a phrase by Elizabeth Warren's campaign slogan in 2016, "I want big structural change," which I think was an effort to speak to an opposite ethos, which I'll call a structuralist ethos. And this is often cashed out as anti-individualist, which is to say, it comes out of an idea that focusing on individual frailty is problematic, often because it's thought to be distracting from the real source of the problems and ineffective. Those real sources of problems, if we're talking about health disparities, might be bad public policy, they might be certain forms of ideology or certain political economies. The social determinants model of health certainly operates in this general sort of a vein. And here too, there's a whole world of empirical research, and I would cash it out as identifying drivers of problematic outcomes that are exogenous to individuals. So some examples here might be focusing on social inequities of the sort people have been talking about today, or bad policy design, the way our built environment is structured, norms, which you might think of as existing out there in social space, or various forms of political economy, depending on your politics and your political stripe. These ideas are old, if that's not already clear, dating back to the birth of the social sciences in works by people like Marx and Durkheim. But the debate between the individualist ethos and the structuralist ethos is very much alive and well. One prominent example is a recent article that has gotten a lot of attention in the journal Behavioral and Brain Science, contrasting what Nick Chater and George Lowenstein call the I frame and the S frame, the I frame standing for individual frame and S frame standing for systemic or structural frame. And the argument basically goes like this, that I frame solutions to a whole host of issues, from climate change to discrimination, to misinformation, to gun violence, have severely limited effects, that behavioral science for decades has been enthralled with I-frame solutions with little to show for it. When specifically talking about health behavior, they have in mind interventions like calorie labeling or exercise incentives, nudges, information campaigns, basically any effort to change individuals' hearts and minds. They make the case that this is to some extent a result of corporate PR. So imagine Coca-Cola pushing the idea of personal responsibility and self-control, while also lobbying governments for favorable S-frame changes, policy that favors their ability to make money. So they say in sum, history shows that the solution to individual frailty is to change the system, not to enhance the individual. Okay. So I want to argue that this picture of choosing between individual change and structural change is an unhelpful illusion. And I think we need a better picture of how social change happens. I have a book coming out with two philosophers, Dan Kelly and Alex Madva, in which we try to paint what we think is a more compelling picture of the interaction between individual and structural change as it applies to a whole bunch of different areas of social change. And I'm just going to today try to very briefly describe three of the topics that we cover in the book. It's not comprehensive, but just three themes. So the first is that it is always both, when we create social change, a reflection of changing minds and changing systems. So the picture here, probably again familiar to everyone, is the famous duck-rabbit illusion, which you can see as a duck or see as a rabbit, depending on your perspective. But the essential point is, if someone were to ask, is it really a duck or really a rabbit at the end of the day, the right response would be that question makes no sense, right? It is a duck-rabbit, the interaction of different features that one can see in two different ways. And I think that's the right way to think about the relationship between changing individuals' hearts and minds and systems and structures. Let me start with a couple examples, or flesh that out with a couple examples. So suppose the thing you're concerned with is opioid use, and you learn that the likelihood of dependency spikes around day 4 or day 5. And so you think, okay, maybe a solution to that is to restrict medical prescriptions to a 4 or 5 day course. Is that an individualist approach to the problem because it's treating the symptom rather than the cause? Or is that a structuralist response to the problem because it's heavy-handed government policy? I think you can make the case for either, and it depends on what priors you bring to the question. Similarly, if you go back to the kind of example that Chater and Lowenstein use about calorie labeling as a solution to overuse of soda and sugary beverages. So to them, this is a problematic I-frame approach, and what they argue for instead are sugar taxes, and that to them is an S-frame approach. To me, this distinction feels cherry-picked. I don't understand why one is I-frame and the other is S-frame. Both require changes in law and public policy in order to be implemented, and both incentivize behavior just through different motivational routes. One by trying to get people to think about the health benefits or consequences of drinking soda, the other by appealing to their pocketbook. I want to just pause for one sec to point out that the kinds of measures that we've been talking about in this session, namely measures of implicit social cognition, which are often maligned as being too individualistic, that is to say, misunderstanding the nature of prejudice because they approach it as something that just can happen inside the minds of individuals, are themselves not inherently individualist. So the IAT and various other implicit measures, as Professor DeHauer just mentioned, can be used to measure collectives themselves. So there's nothing inherently individualist about the measures themselves. So just as it's nonsense to debate whether the duck rabbit is really a duck or really a rabbit, I think it's nonsense to debate whether social change really results from changing hearts and minds or from systems and structures. Individuals are always individuals within systems, and systems are always systems of individuals. The way to think about this instead, I think, is that these are heuristics for training our attention on different features of interventions, just like figure and ground in the duck rabbit. I'm going to speed up here just to get through these last 2 points. The second main theme is the importance of making apples to apples comparisons. So I want to just call your attention to 2 quotes that Keith Payne has said. I'm a big fan of his work. So he says, policies that directly increase racial equality and participation, like voting rights legislation, have more impact than changing attitudes. Solutions need to focus on structuring the social context rather than changing the beliefs or values of individuals. Like I said, I'm a big fan of Keith's work, but I think these quotes don't make sense. On the face of it, there's no way to change social context that doesn't require changing some people's beliefs or values. Voting rights legislation and affirmative action policies require attitude change. Of whom? Well, that's an open question. Voters, representatives, etc. I'm out of time here. If it's okay, I'm just going to make this last point and then I'll skip my third point. I think the charitable interpretation is that what Keith and other people have in mind is that there are some individual things we can do that they think are ineffective, like maybe unconscious bias trainings. I disagree with that, but that's the idea. And there are more effective individual things we can do, like going and voting. But even that is worrying because if you think about the sort of policy changes that people want to contrast with individual change, like say you're pursuing healthcare policy change, it often is the case that what stands in the way of that is individual prejudice. So research from political science shows that one of the biggest impediments to Obamacare was prejudice. So that's what we call in the book the return of the allegedly irrelevant. I'll skip my last point here about structure facing virtues. I'm happy to talk about it in the Q&A and just say thanks very much for having me here. It's an honor.
Thank you so much, Dr. Brownstein. Okay, now I would like actually all of the speakers, if you could turn on your cameras, and I'd like to invite our discussant to turn on her camera. And I'd like to introduce our discussant for this session, Dr. Janice Sabin. Dr. Sabin is a research professor at the University of Washington School of Medicine in the Department of Biomedical Informatics and Medical Education. Dr. Sabin is one of the earliest investigators in the world to apply the science of implicit bias to healthcare disparities research. Her research includes examining patient-provider communication in real-world clinic visits, healthcare providers' attitudes toward race, ethnicity, weight, age, sexual orientation, other areas, and the impact of implicit bias on healthcare. Dr. Sabin is going to provide us with a few remarks, and then we will open it up for some questions and answers. Dr. Sabin? The floor is yours.
Okay, great. Thank you very much. That was a wonderful introduction. And thank you so much to the speakers today for sharing their important work. One of the things that stood out for me was that this session's presentations themselves formed a really energetic academic discussion. We've really come a long way since the 2003 IOM report on equal treatment, which was referenced yesterday, and particularly Chapter 4, which speculated implicit bias may contribute to health disparities and ignited my work so many years ago. So the speakers presented methods to measure indirect attitudes and beliefs, apply implicit and explicit measures to population health, question how we think about implicit bias, and considered at what level we should measure biases. Dr. Axt presented 4 indirect measures of implicit associations, the measure's ability to identify associations and to measure incremental predictive validity, going beyond self-report, and concluding that these measures serve different purposes and are not interchangeable. Dr. Krieger and her team presented work applying implicit and explicit measures to population health research. Multiple types of discrimination were studied using the brief IAT, which doing all those IATs in 12 minutes is amazing, and conventional measures of group preference, exposure to discrimination, and analyzed by target group and dominant group. This work provides much to think about when planning research, given the multiple identities individuals may hold and the cumulative negative effects of experiencing discrimination. Dr. DeHouwer described an alternate way of thinking about implicit association measures. Rather than thinking about implicit bias as hidden attitudes one holds, instead considering implicit bias itself as a behavior that manifests in suboptimal conditions. With an eye towards intervention, Dr. Brownstein debated 2 schools of thought regarding anti-racist moral education, focusing on individual behavior change versus systems change. And Dr. Brownstein described this either-or perspective as flawed. It should be both considered together. I quote from the paper, "Policies make people and people make policies." So in the literature so far, in review articles such as Fitzgerald, Hald, Mania, and a couple others show mixed results on whether implicit bias is a pathway to poor health outcomes. Is this due to context, limitations of the measures, or both? What struck me from these presentations today is the many questions generated from this work that highlight research gaps and opportunities, providing direction for further study. Some of these questions: what do implicit measures currently in use actually measure? What to infer from implicit measures, test, retest data presented today? How to identify pathways to inequity using these measures and real-world health outcomes that can be found in the EHR data? How to best utilize the measures we currently have in health-related research to design interventions to reduce and eliminate disparities? Where do we go from here in measurement? So I'm hoping that people are entering questions in our Q&A. Let's see here. Okay, so I'm gonna, well, first I have one question that I'm going to pose. And it seems as though, and myself as well, we use explicit measures as kind of a, a counterpoint to implicit measures. And my question to our presenters, and anyone can respond to this, is do you have confidence in self-reported measures of attitudes and beliefs? We use this all the time, and we kind of think, well, this is what people think. But don't people, when asked, present themselves in the best possible manner, their idealized view of themselves? And is it possible they're underestimating people's implicit beliefs? And how would this affect the research that we are doing? So I will open that up to, okay, Dr. Krieger.
Thanks. I think that it's really important to think about the multiple stories that people tell. We tell them with our bodies, we tell them with the words that we're able to say and willing to say, depending on who the audience is, and then also potentially by use of measures such as the implicit association test. I think that it's really important. There's one narrative that's out there that people love to claim being victim. Often what's happening is that you're seeing people usually with more powerful positions who are being threatened that like to claim victimhood. And you see often people that are actually much more likely to be subjected to discrimination and oppression to not want to claim that victim status because it's exactly undermining. So I think that there's real possibilities for inflation and deflation of what the actual experiences are that people have, depending on what their target versus dominant group position is, and that these are questions that need to be answered empirically. There's not an a priori philosophical principle as to which is right for looking at particularly health outcomes. Similarly, as with the argument about quote unquote individual versus structuralist, I mean, this plays out in many different theories of disease distribution in different ways of biomedical and lifestyle versus the many different socio-political and other kinds of analyses, is that the body is where it comes together. We embody the conditions in which we live. So there always are individual bodies, but the social context is what matters. And that shapes what happens with what you're asking in your question. It can't just be that what self-report is not part of the story, because that's a huge way in which we communicate, interact with others, and engage, but it's not the full story.
Thank you. Anyone else have any thoughts?
I mean, I would just add, I think in a similar spirit, that self-report measures have flaws, just like all measures have flaws. And I think the important question is not sort of which is better on some absolute scale, but what the forces are that push people's verbal reports around in different sorts of ways, and what are the forces that push people's scores on implicit measures around in different sorts of ways. And so while self-presentation is going to be one sort of confounding feature of what people tell you on a questionnaire, it may be a different kind of a thing that pushes people's responses on different kinds of implicit measures around. That is a very different kind of a concern. And then even, going back to Jordan's talk, when you compare different sorts of implicit measures, you find different sorts of things pushing those scores around. So I think that the question is not just sort of a comparative or relative one about the absolute virtues of different sorts of measures of attitudes, but what is it that you're trying to do with a particular measure, and what are its strengths and vulnerabilities for doing that?
Okay, Dr. DeHauer.
Dr. DeHauer, you're on mute.
So I agree with what Dr. Brownstein said, and it's not, from a behavioral perspective, it's not only looking at the forces that drive the measure, but also what are the forces that drive the behavior that you want to predict. And there too, it's important to analyze not only the measure, but also the behavior that you want to predict, and predict the validity. Logically, it's an empirical question, but logically, predictive validity will be highest when the forces that are driving the behavior of the measure are the same as the forces that are driving the behavior that you want to predict.
And Dr. Krieger.
Thanks. I think another point that I really want to underscore here that our work is showing as well is it also, to answer that question, it really does matter, as I was alluding to, whether one is in a target or dominant group. And I want to make that point specifically right now around research around racism in the US. So for example, you will now find increasingly, and the trend is over time, for self-report among people that are self-identify as and or labeled as, for example, white non-Hispanic, are reporting more discrimination against themselves as white people, which can actually be reframed as racial resentment for advances in racialized justice in this country. So understanding racial resentment is not the same as understanding being the target of racial discrimination. And if you don't understand who's the target group and who's the dominant group, and that gets looking at structural conditions, not just individual opinions about them, you miss the entire point.
Okay, one more on this and then we'll move on. Sorry.
Yeah, I mean, what relatedly, I think one of the things from our study that sort of to me is intriguing was that when we were looking at social desirability measures, it wasn't correlated with every measure, right? So it wasn't, for example, correlated with the racism experiment, right? But it was for sexism and cissexism. So I just want to underscore that it also depends on the type of discrimination that we're talking about potentially, and the need to really consider the heterogeneity of those experiences as well as consider them together.
Yeah, this is very nuanced work, and it's really interesting. So Dr. Barksdale, are you going to answer the next question? Okay.
Yeah, I can post the next question. So we have a question. So what are the opportunities for scientific advancement in the field of measurement pertaining to interpersonal biases in health? Yeah, Dr. Axt.
I can get us started on this topic. I think one thing that's becoming increasingly more popular across the social sciences is this a more intersectional perspective, the fact that people occupy multiple social identities at one time. And all of the data I presented today, they just focus on one social identity at a time. So your racial-based biases based on gender. And so I think it'll be interesting in the years to come to see if we can build these implicit association measures that better account for the fact that people occupy multiple social identities, and do those in turn show greater predictive power. We've, in my lab and some unpublished submitted work, have tried to do just that, to look at interaction studies where people are interacting with, for example, a Black man target, and then we see if we can predict their behavior in that interaction from both just their more racial biases in general or their racial biases specifically towards Black men. And we don't see much of a difference there. So you might think that based on intersectionality, we would expect greater predictability from a more specific measure, but here it does seem to be the case that it's not so straightforward. But surely there are other outcomes where these more intersectional perspectives are going to be more influential, and identifying and anticipating those are going to be important in the years to come.
Great, thanks. Dr. Krieger. Yeah.
Two comments there on opportunities. One that our work is really hinting at, and we'll be doing more on this, is the concerns about, and this ties to questions both of self-report, but also what may be relevant in terms of even the expression and changes and shifts in implicit bias, is a socio-political context. What does it happen when you start to take the lid off of making it be more publicly permissible because of the presentation and behaviors of political parties to valorize dehumanizing others, for example? That has consequences. And so it's not that these are static relationships. And so we're working on figuring out, we're showing in the work that we've done thus far that the socio-political concerns context actually really does matter. And there's other research in social epidemiology that demonstrates that in terms of understanding what health impacts are on people. And so I think it's really going to be important, and this ties to the structure, agency, individual, social, et cetera, to recognize that individuals always do exist in a context, and that is, among other things in this field, very much so a socio-political context, and that needs to be carefully quantified, because you can have that be also part of the roots that are leading to whatever is the resultant outcome, whether it's called the health behavior, health practice, embodied health status, et cetera. So I think that's one part that's going to be really important. And I think on the intersectionality, too often it gets reduced in the literature to being a matter of multiple identities. It's the framework of intersectionality, coming specifically out of Black feminism in great part, is very much about interacting systems and the consequences of those systems interacting and what system change is about for individuals that are caught up in them. And I think that what some of our results are beginning to show, we're really eager to see this for other outcomes, is that probably I'm getting less interested in attempts to try to model things with multiple interaction terms, which impose all kinds of different statistical questions of functional form and otherwise. And instead, this approach that we've taken of the novel approach of using meta-analysis across the multiple types and taking into account the number of groups of which individuals belong as target versus dominant may be a more promising approach. But to me, that's a completely open question and needs to be investigated in much larger data sets.
Great. Thank you. Other thoughts about opportunities for scientific advancement? Yes, Dr. DeHauer.
Here I see work like Jimmy Calancini and Keith Payne, who started using implicit measures at the group level. I think there's much progress to be made there and much potential, whereas individual measurement at the individual level tends to be unreliable. Added value tends to be there, but small. The measures at the group level tend to be much more reliable. And I think also there could be much more predictive validity there. Of course, we have to make that shift from thinking just about individuals to thinking about groups as systems as such. Of course, they exist of individuals, but they are systems that can be treated as behaving systems, just like individuals are behaving systems.
Mm-hmm. Excellent points. Any others? Yes, Dr. Brownstein.
Just a very quick addendum to what Professor DeHauer said, which I completely agree with, which is that I think it's an opportunity for cross-disciplinary collaboration, because one of the, I think, questions methodologically for using implicit measures to look at collectives at the state or national level is how you do the sort of cross-sectoral regression analyses. And that gets into the kind of hornet's nests of problems that political scientists and economists and sociologists have been dealing with for a long time. And so I think that's one of many areas where that research stream has a lot of potential and a lot of work to do.
Great. And I see there's a chat just recommending Lisa Boleg's work on intersectionality for those that are interested, which I second, co-sign that for sure. So related to opportunities, I think the flip side and a kind of second follow-up question. So then what are the most critical gaps in the field of measurement pertaining to interpersonal biases in health? And how can future research address these gaps? So we've talked a lot about opportunities. What are the most critical gaps, particularly in the field of measurement?
Well, maybe I could just start. I think reliability is still an issue, and that's just the start of it. At the individual level, definitely, if we want to make statements about individual, even the IIT is not there yet. You'll need much more. You'll need much better measures. What I also think a challenge is for the field is to convince people who make these measures and who develop these measures to look at utility. I think the field, I've been engaged in the field for 25 years now. The field has been very focused on the scientific part of it and using these measures in research. But I have seen very little convincing research where these measures have made the difference in real life. And I think we need to have a community of researchers who really believes and wants to commit to investigating the practical utility of these measures.
Yes, Dr. Sabin. We
Hi.
still have a minute left, but yes, please go ahead.
Well, I just find the challenge of actual, to build on that, applying these measures, what we have now is not adequate to truly understand, objective health outcomes as reported in the EHR, which is something that I think, for example, blood pressure control, A1C, the measures that we have for people's actual health. And, I'm sort of in the realm of, patient provider interactions. How do we get from what we're measuring now to really actually understanding why there are differences in behavior?
Great. Dr. Krieger, we have just a few seconds left. Do you want to wrap us up here with this last thought?
So two things. One is that I'd also caution about framings of data as objective or not, including in ERHR, because of all the work now on algorithmic bias, for example, that's going on. And that gets baked in also in terms of what's being discussed of physician, or healthcare providers, whoever they are, in terms of what they actually do and engage with and report for patients. So I think that there's a recognition of the fact of the biases that run throughout. All people are people. They are in a context in a society that has great amounts of injustice in it, that get baked into ideological systems, into systems in which people learn and also need to change. So I think that it's really important to be conscious of how do we, going forward, understand the multiple types of injustice that are functioning together, and where can that injustices be changed. And that these data that we're presenting here, it's not to just show them as an end to themselves, but also to conscientize people to understand what is going on, the experiences that people are having, that they are not just personal experiences, they are part of a group phenomena. And this ties to the question of what I think Dr. DeHauer is getting at in terms of looking at collectivities as well. And that becomes one of the challenges that we have. And that's, again, where I think it's going to be critical to bring in not only sociopolitical measures, but also to remember that for the health outcomes, there's lots of biophysical phenomena that are socially structured, like air pollution. Like right now, we're having a heat wave in my city, and who's able to live in a cool apartment or not, has green space or not. And these things can also impact on the exact same kinds of health outcomes that are being discussed. For example, people's cardiovascular function. So I think that separating the psychological world from the biophysical world is really not a good idea when it comes to health.
Thank you. Well, thank you so much to our panel and to our discussant, Dr. Sabin. We are at time, and I want to, again, give a virtual round of applause to our panel and our session speakers. And I'd like to announce our Flash Talk Session B is up next. Thank you all.
All right. Good afternoon, everyone. Perfect. Good afternoon, everyone. My name is Dr. Yewande Oladende, and I'm a program officer in the Division of Clinical Health Services Research at NIMHD. And I have the pleasure of being the moderator for the flash session this afternoon, the second flash session. And with that, I would like to start off with introducing our first speaker. And our first speaker is Dr. Billy Caceres, and he's from Columbia University. And he will be presenting on understanding the influence of interpersonal biases on physical health outcomes among sexual and gender minority population. Over to you, Dr. Caceres.
Thank you very much. I'm just going to share my screen here. So thanks for the invitation to speak to you today about some of the work that we do focus on sexual and gender minority groups. My work primarily focuses on cardiovascular disease risk, with a particular focus on sleep and hypertension risk. So in terms of background, sexual and gender minority adults, particularly sexual minority women and people of color, may be at highest risk for cardiovascular disease due to exposure to interpersonal bias and other forms of stigma, which have been discussed today and yesterday at the intersection of these multiple stigmatized identities. Significant limitations of prior work include, but are not limited to, an exclusive focus on chronic exposure to interpersonal bias, neglecting other forms of stigma, limited examination of mechanisms that link stigma with CVD risk under real life circumstances with many laboratory-based studies, examining these associations, and a lack of attention to intersectionality. For instance, many studies tend to focus on one aspect of a group of individuals' identity rather than asking them about experiences of discrimination related to a number of identities. Today, I'm going to talk specifically about our newly launched R01 study. The purpose of this study is to examine the influence of intersectional stigma on blood pressure and mediators of these associations. We focus on blood pressure because it's the modifiable risk factor for cardiovascular disease with the highest population attributable risk. This model, which is informed by a model of stigma and health, explicates the associations between different types of stigma that we are examining, which include vicarious and anticipated stigma, as well as interpersonal bias. And we posit that these are associated with home blood pressure via a number of mediated physiological, behavioral, and affective factors. We are specifically conducting an intensive longitudinal study of intersectional stigma and blood pressure in a diverse sample of adults in New York City. Half of the sample is sexual minority, half are female identified, 70% are racial or ethnic minority. Participants over a 1-week period complete daily diaries, reporting on different types of stigma that they might experience. They complete home blood pressure monitoring in the morning and the evening, saliva sampling to collect salivary stress biomarkers, and continuous actigraphy to objectively measure sleep and physical activity. Our stigma assessment includes 2 steps. Some people have discussed this today, but participants are asked specifically about each type of stigma with that attribution to a specific identity. Then they're following administration of each instrument. Those that endorse any type of stigma are asked a follow-up question to assess the main identities they attributed to that experience. And I think we have 15 different reasons that we report, and then they have the opportunity to report other reasons. Briefly, our analyses in AIM-1, we are focused on conducting multi-level models to estimate the association between the within and between person associations of daily and chronic intersectional stigma processes with blood pressure and mediators of these associations. Again, those are affective, behavioral, and physiological mediators. And then in AIM-2, we are using multi-level analysis of individual heterogeneity and discriminatory accuracy, and one of several quantitative intersectional approaches to employ categorical groups formed by these intersecting stigmatized identities. And we specifically focus on 4 identities based on our prior work, but we will also have plans to explore other identities. So we're focused specifically on gender, race, ethnicity, and sexual identity. So in summary, this is the first study to link daily exposure to interpersonal bias and other forms of stigma to real-time blood pressure assessment in people's sort of real-life environments. We intend to identify mechanistic targets such as sleep duration, rumination, and other factors that potentially can be used or targeted to reduce the adverse effects of intersectional stigma on CVD risk among sexual minority adults, as well as people of color and women. And findings could support the development of interventions, such as just-in-time interventions that can be delivered in real time to reduce the adverse cardiovascular effects of intersectional stigma on the cardiovascular health of different individuals. Just going to thank the different sources of funding for this, and thank you all for your attention. I look forward to questions in the Q&A.
Perfect. That was perfect timing. Okay, so the next speaker we have is going to be Dr. Heather Farmer from the University of Delaware, and she will be presenting on everyday discrimination and age-related trajectories of blood pressure among Black and white middle-aged and older adults. Over to you, Dr. Farmer.
Thank you so much. Good afternoon, everyone. I'm very grateful to be invited to present this work at the workshop. These are findings that have been recently published in Stigma and Health. So I'm looking forward to hearing your thoughts on this. And I don't see the slides being shared. Mark, are you able to get those?
I don't see them myself. Okay.
Thank you. And can you go to the next slide, please? Okay, awesome. So decades of research has shown that U.S. Black adults exhibit a disproportionately earlier onset of hypertension and also experience a higher average level of blood pressure compared to non-Hispanic white adults in the U.S. Moreover, recent work suggests that these Black-white gaps may also grow with advancing age, suggesting a need to understand blood pressure in midlife and older adults as well. Discrimination has been hypothesized as a key mechanism contributing to racial disparities and elevated levels of blood pressure as well as hypertension risk. However, studies examining this association have yielded mixed findings. And we think that this may reflect various approaches to the conceptualization and measurement of blood pressure. But in addition, existing evidence is also based largely on cross-sectional or limited longitudinal designs, or they're largely focused on younger populations when the levels and changes of blood pressure are maybe less pronounced. So the current study used population-level longitudinal data over a 12-year course to examine how exposure to everyday discrimination is associated with age-related trajectories of systolic blood pressure among U.S. Black and white, middle-aged, and older adults, as well as whether this association varies as a function of race. We hypothesize that as adults age, they're transitioning in and out of social institutions like the workforce, may go into various contexts like healthcare, and as a result, this influences their exposure to discrimination as well as its implications for blood pressure. And that's why we suspect these associations may vary as a function of age. Further, given the disproportionate exposure to discrimination that Black adults experience over the life course, we expected that discrimination would contribute to greater age-related changes in blood pressure for Black versus white adults. Next slide, please. So we used data from about 16,000 adults ages 45 to 85 participating in the nationally representative health and retirement study. To conduct the analyses, we used multi-level growth curve models where we tested 2- and 3-way interactions by race, age, and discrimination. We conducted these models separately for women and men based on preliminary analyses showing that trajectories of blood pressure varied as a function of gender. The models are going to be presented in the next slide, or the findings from those models. So for men, we found a significant 3-way interaction for age by discrimination by race. The figure here plots the results from our analyses. The dashed lines indicate low levels of discrimination. Solid lines indicate high discrimination. The gray lines are for Black men, yellow lines are for white men. So what we found is for the most part that Black men tended to have higher levels of blood pressure across the age range that we studied. In addition, for Black men, we found that more discrimination was associated with lower levels of blood pressure, but only in middle adulthood. And high discrimination was associated with higher blood pressure at older ages. And we found that the patterns were actually the opposite for white men. In the next slide, we present the findings for women. And so for women, we found that there were significant 2-way interactions for discrimination by age and race by age. Overall, we found that blood pressure was generally higher in Black women, and that Black women with more discrimination had lower blood pressure at oldest ages compared to Black women reporting less discrimination. The patterns were similar for white women as well. Altogether, our findings provided us with next slide, please. These findings provide us with new insight on the heterogeneity and the experience and consequences of discrimination in later life. We found that the associations for age, discrimination, and blood pressure was complex and dynamic. It varied by gender, race, and age at times. In order to move the field forward, we suggest that additional studies are needed to explore the type and timing of discrimination that may be linked to advancing age. People who are older might be experiencing age-based discrimination or disability-based discrimination for the first time in their lives. And this can provide new and informative insight into the ways that discrimination can impact blood pressure. And the last slide is just a thank you to my co-authors and collaborators. Thank you all so much.
Great. Thank you so much, Dr. Farmer. So we will be taking questions at the end. But you can also drop your questions in the chat if you have any questions as these presentations go along. The next presenter is Dr. Mary Gerard, and she will be presenting from Florida State University College of Medicine, and she's going to be presenting on identifying pathways linking weight stigma to poor health outcomes. Over to you. I don't see you. Is Dr. Gerard on?
I'm sorry, I'm here. 1 second. Let me share my screen. Can you hear me okay?
Yes.
Perfect. I needed to do that first. Okay, can you see my screen?
I do see it, but it's not in presentation mode. Now it is.
Okay, perfect. Hello, everyone. Thank you for allowing me to join in this workshop today. My name is Mary Gerard, and I'm going to be talking to you about some of our work aimed at identifying pathways linking weight stigma to poor health outcomes. And I just wanted to say I decided to approach this giving kind of a broad overview rather than diving into a specific study. So people with high body weight or people with obesity remain one of the most highly stigmatized groups in the United States. By weight stigma, I'm referring to the social devaluation of people with high body weight as expressed through negative stereotypes, prejudice, and discrimination. Weight bias continues to be a problem in our society due to the mistaken belief that body weight is completely controllable through diet and exercise, and thus people with high body weight are personally responsible for their condition. Similar to other forms of discrimination, we know that weight stigma is associated with poor health outcomes. For example, large-scale epidemiological studies have shown that people who report experiencing weight discrimination versus those who do not have higher risk for future weight gain, depression, anxiety, and substance use, chronic conditions like high cholesterol and diabetes, and even premature death. Importantly, these associations continue to hold after controlling for body mass index or BMI, suggesting that there's something about the social experience of being devalued for one's body weight that is harmful to health. I have two main goals in my program of research. The first is to identify psychological, behavioral, and physiological mechanisms through which weight stigma harms health. And then the second is to identify risk and protective factors or moderating variables. We know that people respond differently to weight stigma, and I think we can learn a lot from those differential responses. We use a variety of experimental methods, research methods in our work, qualitative interviews, survey-based research, observational studies, as well as experimental designs. One thing that I've really tried to make an important goal of my work is to expand this literature to socially marginalized groups that have traditionally been left out of the weight stigma literature. So here I'm primarily talking about racial and ethnic minorities and sexual minorities. Here's a conceptual framework that provides kind of an overview of our work. And I'd just like to acknowledge the amazing group of scholars at the bottom of this slide on which this framework is based. So essentially, we argue that weight stigma is a stressor that triggers a host of psychological, behavioral, and physiological responses that contribute to poor health outcomes. So with respect to psychological responses, here I'm talking about factors like negative emotion. For example, to what extent when someone is exposed to weight stigma, do they experience sadness, anger, shame? We've also looked at factors like executive function or self-regulatory ability. With respect to behavioral responses, we've mainly focused on health risk behaviors. So for example, we demonstrated in a recent paper that people who reported versus did not report experiencing weight-based discrimination reported higher risk for engaging in binge eating, emotional eating, problematic drinking behavior, cigarette smoking, and disturbed sleep. We've also looked at examination behaviors such as social avoidance or social withdrawal. In terms of physiological responses, the main variables that have been looked at include cortisol, cardiovascular reactivity, and inflammation. I wanted to wrap up by identifying what I see are some important gaps in this literature. So I think it's important that we continue to devote time and energy to identifying moderators and mediators of the link between weight stigma and poor health outcomes. I'd also like to see more work aimed at examining the health consequences of weight stigma in socially marginalized groups and assessing how weight stigma might interact with other forms of discrimination to harm health. Similar to what we've been talking about in some of the other sessions, there's a lack of strong measures to assess people's experiences with weight stigma. And so if we invest time and energy into developing those measures, it's important to ensure that they capture people's experiences from a variety of different cultural backgrounds. And then last but not least, I think it's very important to invest in longitudinal studies on weight stigma and health. And I thank you for your time.
Thank you so much, Dr. Durand. Next up, we have Dr. Lauren Hamel from Wayne State University, and she will be presenting on investigating the link between non-conscious attitudes and non-conscious behaviors in cancer treatment discussions with Black patients and their non-Black physicians. Over to you.
Thank you so much. Hi, everyone. So today I'm going to provide a brief presentation on our program of research I've been leading to examine the potential link between non-conscious attitudes like implicit bias and non-conscious behaviors, and that's specifically in oncology treatment discussions between Black patients and their non-Black physicians. And so what prompts this research is the consistent data that we see that there are clinical communication disparities that are based on patient race. So we see that clinical communication with Black patients is often of lower quality than clinical communication with white patients. And as a part of that, we investigate attitudes of patients and providers, and in particular, physicians' implicit bias, and also clinical communication as contributors to disparities in treatment and other outcomes. And I do this by looking very specifically at nonverbal communication. And as a part of that, I've examined discrete nonverbal behaviors like smiles and leaning in. But more recently, I've been looking at more jointly determined nonverbal behaviors in patient-physician interactions, and then investigating predictors and outcomes of that behavior. So we have a saying in communication science, which is you cannot not communicate. So even when you're not saying something, you are still saying something. And it's really important to examine nonverbal communication because this is where attitudes are most likely to be expressed through more like less deliberate communication, like our facial expressions and our postures, than through more deliberate communication, like the words that we speak. And so as a part of that, my team and I have been investigating nonverbal synchrony, or the non-conscious coordination of physical movement that occurs between individuals in an interaction. And we've been looking at it because it's a non-conscious behavior that occurs between two people, but also because previous research has shown that it acts as both a consequence and a predictor. So we see that people will synchronize more with others with whom they have positive relationships, with people they trust. It reflects positive affect and liking and similarity. But more germane to the current context, we also know that synchrony influences the therapeutic process, cooperation, adherence, and memory. And so my team and I have been working on this. There's a few screen grabs of the papers that we've published over the last couple of years. But for today, I'm focused really specifically on one hypothesis in this work, which was in clinical interactions between Black patients and their non-Black physicians, race-related attitudes and perceptions will be associated with nonverbal synchrony. So to test this particular hypothesis, we conducted a secondary analysis that included 68 Black patients. The mean age was just under 50 years, all females, and they were meeting with one of 13 medical oncologists. And the data we had for this study included video recorded clinical interactions, patient and physician demographics, and patient and physician pre-interaction race-related attitudes and perceptions. So for physicians, we had measured their implicit racial bias. For patients, we measured group-based suspicion of medical care, trust in physicians and medical institutions, and their experiences with previous discrimination. To assess nonverbal synchrony, we submitted all of our recordings to motion energy analysis software, which assesses behavior at the pixel level. So we're able to measure that jointly determined measure. And we looked at a few different outcomes. This software gives us 3 in particular. First is global synchrony, which is all correlated motion. Synchrony when the patient is leading the interaction, and synchrony when the physician is leading in the interaction. And we conducted our analyses using multi-level models. So here is a summary of our findings, and I think you'll notice right away that we found 3 significant positive relationships between physicians' implicit bias and global synchrony, synchrony when the physician is leading, and synchrony when the patient is leading. And then we also found 1 relationship between patient levels of trust in their physician and synchrony when the patient is leading. So as we kind of consider these findings overall, keeping in mind, of course, that this is a secondary analysis, before I think about interpretations, I think what it's important to note is that people who study communication, we're really good at counting. We can count smiles, we can count questions, but ultimately at the end of an interaction, you just have a few sums. And so I think what's really important is how this really moved communication work forward, because we were able to look at first a jointly determined measure, but also one that we can see change in over time. So that being said, it's kind of, we need to interpret what these findings mean. And my team and I have some suggestions. It seems that race-related attitudes and perceptions are affecting synchrony. What this means, it could be that non-Black physicians are adapting their behavior by following their Black patients' behavioral cues, perhaps unintentionally. Black patients and non-Black physicians' non-conscious processes potentially were trying to operate to overcome race and cultural barriers through behavioral matching. There's also evidence that individuals with higher levels of implicit bias may try harder to control their biases, and this could be evidence of that. And in terms of patients, it could be that a more trusting patient facilitates the physician's behavior. So potentially physicians are behaviorally adapting to their patients. So that's our ideas here. A lot of this work is under review currently. And as I finish, I just want to say thank you to my co-authors and my grant support, which did include a grant from the NIMHD. So thank you for that.
All right, thank you so much, Dr. Hamel. And last but not least, we have Dr. Tiffany Johnson from the University of California, Davis, and she will be presenting on children and adolescents' experiences of interpersonal bias. Over to you, Dr. Johnson.
Thank you so much for having me here today to represent the clinician scientist, pediatric clinician scientist perspective. Let me go ahead and share my screen. Okay, are you able to see my slides?
Yes.
Perfect. All right, so I really just want to first start by anchoring this discussion by explicitly talking about racism. So although there are many different definitions, I particularly like this one coined by Dr. Kamara Jones, who defines racism as a system of structuring opportunities and assigning values based on the social interpretation of how one looks. And what it does is it unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities, and it saps the strength of the whole society through a waste of human resources. And we all know that racism exists on multiple levels, all of which impact the health and healthcare of children and adolescents. So first you have structural racism, referring to your policies, laws, regulations that systematically result in different access to services and opportunities based on race. But then we also have your interpersonal racism, which is really the focus of this two-day workshop that includes implicit bias, explicit bias, overt discrimination, and microaggression. So even though we've been talking about interpersonal biases this whole time, I just want to acknowledge that this is racism. And then finally, you have internalized racism, which happens when members of minoritized groups who experience structural and personally mediated racism then accept these negative attitudes about their own abilities and self-worth. I think it's also really important that as we talk about interpersonal racial bias, we really need to understand that the associations that one holds towards different groups of people don't exist simply because of in-group and out-group preferences. Instead, this figure really helps to illustrate how our interpersonal biases exist as a result of priming, associations, as well as assumptions. And so when we consider tools like the IAT, the implicit associations that we have for Black, Hispanic, and Native faces with bad words like terrible, horrible, evil, awful, agony, and hurt, they don't just occur by chance, but instead, these are associations that were created by design, and they've been reinforced by means of priming via popular culture, news, and media. And so it's therefore by design that Black people are viewed as violent and less intelligent and lazy, and even dehumanized and likened to animal. So there's so many gaps and opportunities for us to really generate the science that leverages this link between interpersonal biases and structural racism, both when considering causes as well as when thinking about our interventions. And so this must be a theme for the last presenter. Instead of focusing on data in any of my individual research studies, which I'm happy to link in the chat later, instead, I really want to provide more of a high-level overview of how children and adolescents experience interpersonal bias across pretty much every domain of their lives. So starting with healthcare and building on Dr. Hagiwara's presentation yesterday focused on the role of healthcare providers' bias in racial and ethnic healthcare disparities, we need to acknowledge that children are not immune from this. So in pediatrics, racial disparities exist in multiple areas, including doctor-patient communication, which was just reviewed by our last speaker, as well as things like even calling security on patients' children and their families. And there's also some emerging evidence on stigmatizing language in the electronic health record. And we also know that when you look for disparities in care, you find them. So with this recent scoping review, we documented disparities across specialties and pretty much in every area of pediatric healthcare that was examined. So while we have clear evidence of bias and behavior based on these disparities in pediatric healthcare, more work really needs to be done and demonstrate this causal link between interpersonal bias and patient outcomes, but more importantly, to understand how we can modify provider behaviors in order to improve our patient outcomes. So it's important to note that children and adolescents who have been racially minoritized, they're exposed to racial bias across many domains of their lives beyond healthcare. So when thinking about neighborhoods, for example, a key social determinant of health, we know that beyond structural level racism with documented practices like redlining, implicit and explicit biases also contribute to discrimination in rental screening applications, current mortgage lending practices, appraisals that devalue the houses of Black homeowners and their neighborhoods. And so these discriminatory practices really influence where children live, which is the social determinant of health, as well as their opportunities across their life course. Moving to education, disparities in suspensions and expulsions have brought lots of attention to the bias in the educational system. And so we know that through the IAT, teachers have demonstrated pro-white, anti-Black implicit racial bias, as well as explicit perceptions that Black students are angrier and more dangerous. We also see the adultification of Black students who are perceived as older than their peers, resulting in really unfair expectations for developmentally appropriate behavior, and even policies discriminating against ethnic hairstyles, such as the locks that I'm wearing today. And then we can't talk about interpersonal bias in children without also talking about the role of law enforcement. And so research has really helped illuminate how implicit dehumanization is linked with police officers using greater force against Black children relative to children of also races. But similarly, we also know that even towards children who have survived sexual abuse, Black and Hispanic children are explicitly perceived as more responsible for their abuse than their white counterparts. This is really important because I want to highlight that racism in all of its forms, including interpersonal bias, impacts health and wellness of children and their families across a variety of measures. Some of these things have been studied in children. Others, which we talked about in other presentations, have primarily been focused on adult populations. But a life course perspective really acknowledges that early childhood experiences of social disadvantage, including interpersonal bias, can trigger a variety of physiological responses, and the cumulative impacts can really shape their health outcomes across generations. So as we head into the discussion phase and we think about challenges and gaps and opportunities, I really just want to highlight the impact of impersonal biases towards children and its link to health outcomes as a critically important area of research, and recognizing that interventions are really urgently needed that can have impacts on their life trajectory.
All right, thank you so much, Dr. Johnson. So we do have about 15 minutes for Q&A, and I would like to ask all the panelists to come back on camera. Also, while we're doing that, because we may not have enough time to answer all the questions, there are some questions in the Q&A. If you click on the Q&A box, there's some questions that have been put in there. So if you have anyone addressed to you specifically, directed to you, please start answering those. But I'll start off with a question or two questions for all panelists. So what are the opportunities, both practical and scientific, that's available to make progress on the science of interpersonal biases in relation to health? So when you think about the gaps, what are some of those opportunities that exist for some of those opportunities that exist towards making progress in this area? And anyone can start.
I can start off since I'm actually still unmuted from my last presentation. So I think I tried to highlight some of these in my presentation, but there are a lot of gaps when we think about measures that can be administered to children. So for example, I'm involved in a study right now that's looking at disparities in childhood sleep. And we're looking at measures of discrimination that are related to that. And so we have some measures looking at at internalized racism with a Clark Dahl study, but there are really not any measures that are validated on experiences of bias and discrimination in our youngest children. And so we're using proxy measures from their parents and adult experiences of discrimination, as well as some teacher studies looking at implicit bias using the IAT. But when thinking about our pediatric patient populations, I think it's important that we begin developing and validating measures in our younger age groups so that we can really begin to study these instances of bias and how they impact children across the life course.
Okay, would anyone else like to chime in on that question?
I mean, I think my presentation sort of focused on this, but I think that I think that there's pushback from what I've seen in terms of within this type of work to do more intersectional work, in terms of people feeling that asking about intersectional experiences somehow diminishes other specific identities that people might hold, that researchers assume are the most salient identities that our research participants hold. And I think that there needs to be, if we're talking about moving the field of interpersonal bias forward, I think we need to do a better job of training the next generation and current researchers that are reviewing papers and grants focused on this topic about intersectional work and the importance of intersectionality, because I think I've seen some hurdles in terms of moving that work forward from a number of, and I've heard of that from a number of different colleagues as well.
Thank you, Dr. Caceres. So it looks like we do not have 15 minutes like our audience stated, so we only have 4 minutes left. I'm going to take a question from the Q&A that I see put in there, but please pose your questions, or please respond to the questions as you are able. So this is for Dr. Johnson. Can you please talk about more specifics of what kinds of language is found in the EHR?
Sure. And I think this is an increasingly important issue as we now have open electronic medical records. So our patients, and for me, our families can actually view what we're documenting in the chart. So examples from research including things like statements that indicate disbelief about the patient. So in a specific example is, a patient who comes in with sickle cell disease and pain, and then the provider charts, patient claims pain is 10 out of 10, but is on their cell phone. Or, the patient's girlfriend is in the bedroom sitting on the bed, using quotes in a mocking way. So those are some other examples. And so I think this is really important. There's also some growing literature that shows that when the next provider then reads some of this language that's more stigmatizing in the chart, it actually biases the next provider, and then it can impact treatment recommendations, including pain management. So I think that this is a growing area and an important area of research for us to consider.
Okay, thank you, Dr. Johnson. There's another question here from, this is for Dr. Duran. And the question is, this person, Gina, would like to get your thoughts and find out if there's been any work on two topics. So provider weight bias having a direct impact on health outcomes via medical decision-making. Do you want to address that first? And then the second one is on the term atypical anorexia to describe people with larger body size who have anorexia symptoms as a form of weight bias.
Thank you, and thank you for the question. I have seen some some research on weight stigma in healthcare settings with healthcare providers. I have not seen it, though, however, linked to health outcomes. So I think that is an important gap in the literature. It's mainly been qualitative and descriptive in nature for the most part. It's definitely widespread. I don't think all providers are intentionally trying to be biased against their higher weight patients. I think it's part of the culture of medicine, unfortunately, and is a very, very important area for future interventions to try to reduce and come up with language that providers can use to help make their higher weight patients feel more welcomed and more receptive to their recommendations. And I'm sorry, the second question, did you want me to jump into that now or move on to something else?
Should I read? It's right.
use of the term atypical anorexia nervosa to describe people with larger body size who have anorexia symptoms as a form of weight bias and/or an avenue through which weight bias can flourish. It's funny, my students actually presented a paper on this topic this past semester, and it was a new area of research for me. So I have to say I don't know too much about this line of work, but I do see that it is starting to get some attention in the literature. And thank you for the recommendation to look into that further.
I think there's one more question for you, Dr. Duran. So the speaker is asking, Ariel is asking if you could speak more about the overlap between weight stigma and other forms of stigma against populations that experience health disparities.
Yeah, I think there's not a lot of hope. There's not a whole lot of work in this area for sure. So that is a definite gap that I've seen. One thing that I have seen is that we're seeing weight stigma in lots of different communities, in racial and ethnic minorities and sexual minorities. We do see some differential kind of reports in terms of frequency or prevalence, but we're talking about small differences. So it's a statistical difference, for example, between Black women in terms of reporting frequency of experiencing weight discrimination compared to non-Black women. But it's a small difference, like 50% versus 54%, for example. I don't know if that's exact, but it gives you an idea. But one thing I'd like to underscore is we're seeing similar relationships between weight stigma and health risk behaviors, for example, suggesting that the strength of the relationship is not differing across different groups. And I'll stop there.
Okay, there's one last question in the chat, which we will not be able to get to. But if you're able to just type your response in the chat, that would be great. At this time, we will be taking, well, I'd like to thank all the panelists. Thank you so much for your presentations. And we will be taking a 5-minute break, and we'll be back at 3:25 Eastern Time. Thank you, everyone.
All right. Welcome back, everyone. My name is Ariel Gilman, and I'm a program officer in the Division of Integrative Biological and Behavioral Sciences at NIMHD. And I will be moderating our final thematic session of the day, which is titled Evidence-Based Interventions to Mitigate the Influence of Interpersonal Biases on Health Outcomes. So our first speaker today is Dr. Calvin Lai, who is an associate professor of psychology and criminal justice at Rutgers University. He's also a member of the Scientific Advisory Board at Project Implicit, a nonprofit for research and education on hidden biases, and will be presenting on mitigating the impact of implicit bias. Dr. Lai studies the spontaneous or unconscious mental processes that create a gap between what people value and what people do, and focuses on developing interventions to mitigate the effects of hidden biases and studies, reducing implicit bias, preventing hiring discrimination, mitigating racial inequities in policing, and increasing women's interest in pursuing careers in science. So please join me in welcoming Dr. Lai.
All right. I hope you can see my screen, and I hope you can hear me.
All good.
Great. Okay. I'll just get right into it. So I'd like to, first off, I just moved over to Rutgers. I was at Washington University before. If you want to visit my lab website, it's still technically at WashU. Anyways, moving on. I'd like to start off with a big, or a quote of sorts, and here's the quote. One of the major changes in U.S. race relations involves a shift from blatant discrimination to more subtle forms of racism among whites. And in Kelman's terms, whites have begun to comply with an egalitarian and non-racist ideology. Let us hope that internalization follows. Now, you might see this quote and you might think, given what I study, given what a lot of people are talking about today, that this is kind of a recent quote from a paper about implicit bias. But what I want to highlight is that it's not recent. It's from 1980, right? That these problems that we're talking about, subtle racism, subtle discrimination, they're not new problems. They're not novel problems. We've been dealing with them for over a generation. And when we think about the kind of different measurement paradigms that have been brought to bear in documenting, measuring subtle racism as it exists in the world, right? We've got these kind of audit studies where you run these real world field experiments and everything is the same except for a person's racial identity. You've got these kind of indirect questionnaires where you try to probe at racial attitudes, using questions that are not directly asking about, say, anti-Black animus. And of course, you've got these kind of implicit measures that try to measure biases indirectly as they're revealed on these kind of ostensibly unrelated tasks. And I want to highlight these three different paradigms, three major ways of thinking about measuring subtle racism or subtle racial prejudice, because one of the things that is really quite disturbing, quite discouraging, is that across all of these different measurement paradigms and theoretical ways of thinking about racism, from what we can see in the empirical data, there has not been much evidence of reductions in subtle racism in the past 2 decades since the turn of the century, suggesting that at least writ large that we've had much success from all this documentation of their existence in finding good interventions. So what I want to do today, kind of leading off this intervention session, is to talk about, to kind of give a kind of whirlwind tour of some of the kind of major approaches that us intervention scientists are thinking about in combating discrimination directly. And I'll drill in on one particular, given that some of the other speakers are going to be talking about some of the other ones. So one of the most obvious approaches, particularly when you're thinking about implicit bias or hidden racism, is to simply reduce it directly, right? Can we reduce these implicit biases? At least some of my work suggests that while we can be incredibly effective at doing it temporarily, trying to change in the long term can be quite difficult. It might require a lot of investment. A second set of approaches involve things like diversity training or diversity education, where you're simply trying to tell people, say, some of the kind of fruits of our labor, right? What do we actually know about the facts on the ground about how racism or how discrimination happens, with the hope that kind of educating about bias would lead to kind of some downstream change in behavior. And a kind of final approach, and the one that I'm going to focus on for today, is thinking about discrimination almost like a design problem, where we can consistently identify as social scientists where discrimination is happening, and we can in some ways put guardrails in place, safety features, to prevent people from running wild with their biases unchecked. So I'll talk more about this particular approach and some of the success that's been found with it, using evidence from other fields, but I'll kind of draw it back to health toward the end. And so this is in some ways a kind of more procedurally oriented or more structurally oriented way of thinking about curbing the consequences of hidden or implicit biases, right? Rather than trying to, say, reduce people's prejudices, we can set boundaries to how they make their decisions, constrain their decisions, so that even if they are, some of the kind of most racist people in the world, right, we put checks on them so that they cannot act on the discrimination so easily. And this is, in some ways, kind of reflecting one of the kind of themes that has come up across today's talks, right? This kind of shift in thinking about bias merely as this kind of psychological thing that swirls around the mind, to more moving to thinking about bias in the kind of form of action or in behavior, somewhat in the way that kind of Jan de Houwer was talking about earlier. And so what we're going to do today is we're going to zoom into hotspots where we know discrimination is especially likely, where the stakes are really high, and we're going to find places where you can put guardrails on decision making so that people's implicit biases are in check. So first off, when we're kind of thinking about where discrimination is happening, where are we going to be really worried? Well, one type of situation is that we can think about when it comes to bias as it's expressed in action is biases in interpretation. Those are cases where you might see a particular behavior and interpret it differently based on whether, say, it's a white patient or a Black patient, right? A yellow flag now suddenly is a red flag. A white patient who's rude might be seen as just having a really bad day, whereas maybe a Black patient isn't given that type of leniency. They're just seen as intrinsically rude, like it's part of their character. Another form of bias that we can think about as interventionists is bias weighting, where we're given a bunch of kind of criteria, say diagnostically relevant criteria, symptoms or things like that. And information is often weighted in a kind of biased manner to justify our kind of discriminatory impulses. So that's a little bit abstract. So I want to highlight, actually not one of my studies, but what I think is a really great classic study that kind of illustrates this problem of bias weighting really well. And we'll talk about a way to kind of intervene on it that has kind of broad sweeping implications. Okay, so this is a study. Researchers had participants come to the lab and select one of two candidates up for promotion to police chief. One was a guy named Michael. The other one was a woman named Michelle. The participants read through the credentials, and they find out that Michael is known as being tough but streetwise. Michelle is exceptional for being a great communicator and formally educated. And what the researchers found in this particular study is that people were more likely to pick Michael for promotion to police chief. And when asked why, they said, it's, well, if you think about what's important to being a good police chief, being streetwise is really important. Okay, that makes sense. All fair and good. Okay. But this is a social psychological study, and us social psychologists love experiments. So there was another experimental condition. These participants came in, and instead they found out that Michael was formally educated. Michelle was tough, but streetwise. So if you assume that people are kind of rational actors that are consistent in their values, of course they're going to pick Michelle now, right? Well, no, that's not what happened. They were still more likely to pick Michael. And when asked why, they said it's because being formally educated is more important. So what we are seeing here is what discrimination often looks like in real life. We're seeing a shift in the very standards by which we evaluate people based on whether they are a man or woman. It's happening, likely happening automatically or unconsciously. When they try to correlate explicit sexism scores with the likelihood of discrimination, it didn't seem to correlate really well. And so to combat this, the researchers ran a second study, and this was an intervention study. And they thought, well, what we're seeing here is that people are shifting around what they think is important to justify how they want to discriminate, right? Engaging in sexism. And so what they did was a simple procedural change. Instead of asking them after the fact what was important for a police chief, they just simply had participants write out in advance, what do you think is important for a police chief before you see any of the candidates? And when that happened, gender discrimination fell down a hole. Now, regardless of gender, people were more likely to pick the police chief that was consistent with the values that they wrote in advance. And the psychological phenomenon that's being targeted here is that people care a lot about being consistent with themselves. They don't want to feel like hypocrites. So if you just simply have people commit to a certain set of rules in advance, then those things are going to overwhelm the influence of discriminatory biases in many cases. So how does this apply to health? Well, certainly, this applies to almost any type of employment decision, but also is applicable to the kind of wide range of decision-making contexts where there is this kind of subjective judgment or evaluative judgment of someone else, right? Like, are they in enough pain? Who should go up for promotion? All of these different things. And the kind of solution here, or at least partial solution to this type of discriminatory bias, is to standardize decision-making ahead of time so people aren't just kind of going willy-nilly on what they think justifies their biases after the fact. And a lot of times this can be an iterative process, right? It can be really hard to make a good rubric or to make a good checklist. But at least what some of the research shows is that when you let that discretion go unchecked, oftentimes what's going to result is discrimination at scale. And there are a bunch of other interventions like this. So Jordan Axe, who actually presented earlier today, and I have this paper finding that even just getting people to pay more attention to the criteria that they committed to in advance also helps, right? That's not just writing it down. You need to really kind of follow through on it. When you're thinking about kind of more conversational context, if you're thinking about things like interviews, right? You can have some of the same kind of ideas here, right? Having structured interviews where everyone is kind of being subject to the same types of questions and ensuring that those questions are kind of tapping into those kind of pre-committed criteria that you had in advance. And some other kind of ways to kind of add guardrails to decision-making to constrain these biases, right? Rein them in as you can, is removing potentially biasing information when it's not relevant. So sometimes that might be, if race is not actually relevant here, don't make a habit of kind of just like poking it out. And a final approach, which again is more relevant for employment, is evaluating people side by side. So if you evaluate a man and a woman side by side, for example, at least some of the research shows that can help constrain biases because people have less wiggle room to run on their unchecked discretions. Now, I want to highlight two limitations to this general approach that I think can be used in a bunch of different places. So while it is this kind of more structural or procedurally oriented intervention, I do want to emphasize, right, that this kind of distinction between kind of structuralist and individualist approaches, as Michael Brownstein was talking about earlier, is kind of an illusion, right? Because even when you do have this type of procedural or policy change, you do need individual actors, say individual healthcare providers, to have buy-in to follow through on some of these things, right? Every single one of us treasures our discretion as part of our kind of daily job of making those kind of hard calls. And so part of what we think of as a way to kind of address that particular limitation of getting people to buy in to these discretion reducing or policies or ways to kind of check their bias, it's to simply, engaging kind of better education or messaging to justify why you really need to focus on them, right? And that can be as simple as a short reminder ahead of time, like, we're about to go into the interview these people, let's go review what we are looking for this job, or things like that. Another issue that I kind of want to highlight as a kind of limitation of this type of approach is that the scope is pretty limited, right? It's about these kind of subjective decision-making contexts that often involve some type of evaluative things. And so the idea here is to kind of complement with some of the other approaches I talked about earlier. And with that, I have to close just on time. Adding guardrails to decision-making reduces discrimination, but do think about buy-in and scope. Thank you so much.
Thanks so much, Dr. Lai, and excellent timing. So we'll invite Dr. Lai back to address questions during the discussion section at the end of this session. And I'll introduce our next speaker, who is Dr. William T. L. Cox, a scientist practitioner in the realm of social justice. Dr. Cox is the founder CEO of Inequity Agents of Change, a 501c3 nonprofit dedicated to widespread dissemination of evidence-based methods to reduce bias, create inclusion, and promote equity. He is also an affiliate of the Center of Demography of Health and Aging at UW-Madison. His work all serves the ultimate goal of understanding and reducing the injustice, human suffering, and disparities that arise from stereotyping and prejudice, and leverages advances in basic knowledge about stereotype perpetuation to develop, test, and refine evidence-based interventions, most especially the bias habit breaking training. Please join me in welcoming Dr. Cox.
Hello, everyone. I'm excited to be here talking with you all today. So this is the title of my presentation, Empowering Agents of Change to Reduce Bias, Create Inclusion, and Promote Equity, 16 Years of the Bias Habit Breaking Training. As the title implies, I'm going to talk about this training approach that my colleagues and I have developed and tested in over a dozen randomized controlled experiments over the last 16 years. I'd be remiss if I didn't acknowledge that doing this kind of work, especially at the volume and size of a lot of our studies, wouldn't be possible without an amazing team. These are just a few of my amazing collaborators who have contributed to this work over the years. Also, doing this kind of work isn't possible without funding. And the NIGMS at NIH has been gracious enough to fund this work over the last 16 years. At this point, over $8 million worth of grant money into testing, developing, and refining this training approach I'm going to talk about today. And because this is only a 12-minute talk, I'm not going to be able to have as much detail as I would like to have explaining our studies. But we just published this review paper. So everything I'm covering today is covered in more detail in this review paper that came out last year. And it's free open access, and you can get it through our website at biashabit.com. So with all that, I'll jump into talking about what our training does. The core of our training is that we built it drawing on existing areas of cognitive behavioral change in science. Things like the habit change literature, clinical methods of helping people kind of change their minds and behavior, like cognitive behavioral therapy, intervention science, and so on. We really, rather than reinventing the wheel, trying to come up with a bias and diversity training from scratch, we really drew on established principles of how we can really help people to tune into biases that might leak into their behaviors, and then how to correct those biases. And our approach focuses especially on motivating people to be autonomous agents of change. That's why my title was about empowering agents of change. We really think about our trainings approach as getting the individuals in our training audiences to take responsibility for bias and equity and diversity and so on, for them to see it as something that's important to them, that is their responsibility to address. And then we try to empower them in their goals to address those various types of biases and inequities by giving them concrete skills that help them develop self-efficacy to address bias. And these skills run across several levels of analysis. So many of the skills are kind of mental exercise types of things that help people kind of tune into how bias is likely to play out for them, and then ways to disrupt or prevent those biases. Similar to what Calvin said before me, the kind of putting up guardrails, thinking about what's important in a hiring decision before you're in the situation to make that decision. That Ullman and Cohen work you reviewed is one of our kind of core skills where we talk people through how to apply that in their everyday lives. So some of these skills focused on kind of reducing bias and addressing one's own kind of cognitions and behavior. Then some involve creating inclusion. This is things like how you talk with people who are different from you, how you create inclusive environments in your workplaces, and so on. And then some of the skills involve promoting equity. So looking at institutional policies, workflows, things like that might contribute to inequities, and how to correct those forms of inequity. And a couple of features of these skills to emphasize. In order to be a part of our training, all the skills have to be actionable. So again, repeating something that Calvin said, moving from just kind of the idea of bias in people's minds to how does bias get to action? All the skills that we work on teaching them involve actually doing something. It's not just knowledge that sits in their head. They actually go out and take action in the world. These skills are also self-sustainable. So it's not just like a mental exercise they do while they're sitting in a training and someone's telling them to do it. It's something that they can maintain over time, that they can keep doing to keep working on biases. We also want these skills to be generalizable. We don't want to have one training that's about race bias and then another training a few weeks later about gender bias, and then a training about LGBT statuses, and so on and so on. We teach these skills and we teach people how to generalize them so they can work at all different types of biases. And then lastly, we want these skills to be customizable. So there are things that pop up in a medical context that are different than things that pop up in a legal context or an academic context, and so on. We develop these skills and kind of teach these skills in a way that people can see how they can customize them to their specific context. Not just across different professions, but even within one profession, the systemic forms of inequity might be different in one doctor's office versus another doctor's office. We're teaching them the skills to identify and correct those things and customize these approaches to their own context. So with all that, I'm going to start getting into some of our data over the last 16 years. So as I mentioned at the outset, these are all randomized controlled experiments where one way or another people get randomly assigned either to get a version of our training or to serve as controls, and then we follow them over time. And some of our very early work on this training, so it got a fair amount of attention because in one of our very first studies, we showed a long-term, long-lasting reduction in measured implicit bias through the IAT. Now, in that initial study, it was run by a student and it was a bit underpowered. There were a couple of problems with it, but it was a good initial evidence that our approach actually helps people reduce measured levels of implicit bias over time. What you see on the screen here is one of our recent replications. This is something that we see fairly consistently across our various studies. People take these skills we teach them, these mental exercises and interpersonal activities that I mentioned before, and they actually start working against bias, and we're able to see that as measured by the IAT. What you can see in the graph here across the top, that's our control condition, where basically they don't change over time in the control condition, but in the bias intervention condition, their measured level of implicit bias goes down and stays down. And I didn't label my time scale there, sorry for that, but that's out to about 8 weeks post-intervention. Now, this is using the IAT, a reaction time-based measure of bias, but we really want to know that it's not just the reaction time measure that we're affecting, that we're actually affecting other things out in the world. The meaning of this the interpretation of this effect depends on, are we actually reducing bias in their other kinds of behaviors, not just on a reaction time measure. So in one of our recent studies, we followed up with people 2 to 3 years after they initially got our training. We had them do a task that was developed by Burns and Monteith and colleagues that is a stereotyping task. And basically how this task works, it makes it very, very easy to make stereotypic assumptions about other people within the context of this task. But if you put in more effort, if you're trying really hard not to make stereotypic assumptions, you can do that. And so it's kind of a proxy measure or a direct measure really of how much effort people are putting in to try to overcome stereotyping. And what we found was that people who got our training, they were lower, significantly lower in their rates of stereotyping on this task, 2 to 3 years post-intervention. And that reduction compared to the control group was significantly mediated by that previous reduction in implicit bias that we had observed. So that was encouraging. That kind of tells us that as we hoped and theorized, that the work people are putting into reducing bias in their minds and in their behavior goes beyond just kind of reaction time measures. Another huge study that we did with our colleague Molly Carnes involved STEM departments at UW-Madison. So these are all of the science, technology, engineering, math, and medical departments, all the departments in our medical school. And what happened in this study, the departments were randomly assigned to either get our training or to serve as controls, and then we followed them over time. In much of our published work, there are various other effects that I'm not going to go into detail on. The training ended up resulting in more positive climate in those departments. People said they took more action related to gender equity in those departments, and so on. But one of the big outcomes that we were interested in was hiring. So one of the big issues when we're looking at gender in STEM context is underrepresentation of women as tenure track faculty. And so what we did is we paired with our HR department at UW-Madison and looked at kind of hiring of new faculty the 2 years before our study started and then 2 years after random assignment. What you see on the screen here, this is the percent of new faculty hires, new tenure track faculty hires who are women. And in the 2 years before our study started, what you see here is the new hire is about 32, 33% women. So well short of 50%, which is what you might expect if there's no kind of biases or inequities kind of working against women being hired. Then we look at the 2 years after random assignment. The control group, their new hires are still at about 32% tenure track faculty being women. But for the intervention group, in the 2 years after they got the intervention, their rate of hiring women jumped up. It's about 47% of their new faculty hires were women after they got our training. The statistical analysis here, this is a contrast where we're comparing those 3 lower bars to the intervention post-experiment bar. It's statistically significant. It corresponds to a 43% increase in hiring of women as tenure track faculty. And because these are real numbers out in the world, that amounts to about 30 more women who were hired as tenure track faculty in those departments that got our intervention. So we found that to be very encouraging. Well, one last study I'll talk about before I run out of time. We did a huge study with teachers and students in a school district in California. 176 teachers were assigned to get our training or to serve as controls. And then we looked at their students' grades and achievement gaps. And the way this works is, the students have multiple different teachers. What our analysis does is looks at how many of their teachers went through our training versus how many were in the control. And what you see on this graph here is that when most of the students' teachers were in the control group, so there's a low proportion of their teachers who went through our training, you see a typical achievement gap. Where the Latin descended students underperform relative to white students. But when the students have a high proportion of their teachers who went through our training, so more of them are in our intervention group, that achievement gap goes away. And importantly, the achievement goes away because the Latin students get higher grades, not because the white students got lower grades or anything. So we're helping them reach parity and eliminating that achievement gap. I was trying to get through as much as I can. We have a lot of other studies. If you read my review paper, you can learn more about it. But the kind of take-home message I want to leave with you is that when we're trying to work on developing these kinds of interventions, one, we can draw on established cognitive behavioral science. We know a lot about what's involved in helping people change their behavior in positive ways. And we can draw on those literatures to make effective interventions. And secondly, some folks who develop interventions put themselves as the trainer, being the kind of agent of change, that they're going to change what's wrong with people who have biases and stuff like that. And really what we find in our training and why it's effective is because we put the locus of change in the individuals themselves, empowering them to be agents of change, believing in the good of people. So with that, I'd like to thank you. My time is up. If you're interested in learning any more about our work, you can go to our website there on the screen, biashabit.com. We also made a podcast version of our training. We're translating the training's content where you can listen to it as a podcast. You can check that out as well if you're interested. And thank you very much.
Thanks so much, Dr. Cox. Again, we will be back to answer questions during the discussion section. So next to speak is Dr. Jeff Stone, University Distinguished Professor of Psychology and Psychiatry at the University of Arizona, who will speak about examining the effectiveness of implicit bias workshops for medical professionals. Dr. Stone's research develops and tests workshops for reducing implicit bias in healthcare by helping providers to understand the nature of intergroup bias, how it influences thought and behavior, and how to develop skills to reduce implicit bias when observing or interacting with patients, staff, and other providers. Please welcome Dr. Stone.
Thank you. I will share my slides. All right, great. We'll want to thank the organizers for inviting me to share the work that we've been doing for a bit here on trying to see what we can do to help medical professionals learn about their implicit biases and see if that leads to any changes in the clinic. I'll jump. I started doing this work with my colleague Gordon Moskowitz. We wrote a paper that was published in Medical Education back about 2010, where we really just tried to talk about if you took the psychology of implicit bias as it currently stood at that time and tried to bring it into healthcare, what would you want to talk about? And we really tried to lay out our model of what we thought would work best at that time. We then received generous funding from NIMHD to try to develop workshops for medical students and residents. We started working with our faculty in medicine at the College of Medicine at the University of Arizona. Learned very, very quickly that we had to think very carefully about how to tailor the materials for being useful for physicians, for healthcare providers, nurses as well. And it wasn't just a straight translation from teaching a course in psychology on prejudice and discrimination. But we also wanted to be able to test whether this was effective. And I'll show you the results of some studies looking at that. And then, of course, we wanted to be able to test whether the intervention influences interactions and, importantly, could affect patient outcomes like patient satisfaction with a clinical visit. So I'm going to show you some of that work as well. So jumping right into the very first study, we ran the first study with medical students, and we were able to run this study essentially twice with two first-year classes of medical students at the University of Arizona. About 54% of the students participated. The breakdown of the demographics where we had 78 majority group, predominantly white students. We had 42 what we call minoritized non-target group members. These are the predominantly Asian and Asian American students in the incoming classes. And then a small sample of minoritized target group members, Black, Hispanic, and Native American students. The term target refers to the stereotype that we're interested in impacting in these studies. It has to do with medical non-adherence. And so the research at the time suggested the Black, Hispanic, and Native American patients were especially likely to be characterized as non-adherent, not so much for Asian and Asian American students or Asian American patients. The students participated in two workshops, and in the first 1 through 3 days of the first workshop, they first completed a Hispanic non-adherence or non-compliance, white compliance stereotype IAT online. We did not give them any feedback. We're worried about their sort of defensive reactions to that. We wanted to control what they thought about when they came into the workshops. We also measured their resistance to wanting to learn about implicit bias. We have the internal external motivation to control their stereotypes, but also a great set of scales by Neal and Shapiro from 2012, theories of racial bias. So this taps into the degree to which people believe they have ideas for how to deal with racial conflict, whether they want to actually learn about their own racism, things like that. These were designed to be measures, individual difference measures that might tap into resistance to wanting to learn about implicit bias through these workshops. Then 24 hours before the workshops, they received lecture notes and readings that were made available online to them. And then 3 to 7 days after the second workshop, they completed that same Hispanic white non-compliance compliance IAT. So the design of this study is just a simple pre-post with everybody getting exposure to the workshops. What do we do in our workshops? Well, we break our workshops into sort of two things. First is what I would call awareness of what implicit bias is. So we would introduce them through a face-to-face lecture to the psychology of explicit and implicit intergroup bias. We would then take them through an exercise. And if you've never done this, I think it's one of the best ways to help people understand and feel their own implicit biases, which is they do a version of the IAT on their lap in the classroom using hand claps. It's a really great way for people to get a sense of what we mean by implicit bias. And then we presented to them research on the effects of implicit bias on clinical care for patients, being very careful to tailor that material to clinical interactions with patients and what was available at that time. Then what we do in the second workshop, they come back sometimes a few days later, sometimes a couple of weeks later, and we created a number of active learning exercises that we run them through for 90 minutes that we think of as skills training. First, we talk about the fact that, to control your level of implicit bias, you need to be aware of when it could happen. And certainly when you're interacting with patients, that's one time when you want to be aware of the possibility of communicating implicit bias. But we're also careful to talk about there are other times when you are making judgments about patients and they're not even in the room. So for example, you may be looking at a history and it says 55-year-old Hispanic male, right? Well, there you go. You've got all the categories you need to automatically activate stereotypes and prejudices. Or maybe you're talking with a colleague about a patient, maybe reading notes. Somebody mentioned that earlier. And that could also provide the information necessary to activate biases that would then leak into judgment and advice you might give somebody. The clinical skills that we teach them are specifically designed to control implicit bias. We've never thought we could change anybody's associations in the time that we get for these kinds of workshops, but what we thought we can do is motivate them to want to change and then show them how they can change. And so a number of things that we've done is create active learning exercises, for example, showing them what kinds of nonverbal cues tend to associate with implicit bias, and then having them work on actually changing the negative nonverbal cues to be more positive during interaction. We also do something kind of similar to what I think Dr. Lai was talking about a minute ago, where we talk about when you come across a patient who's different from you, use their difference as a cue to activate your chronic egalitarian goals, your goal to be fair and just and provide equitable care to everyone. We also take them through a number of exercises where we think about what questions could you ask a patient to discover an identity that you share in common with them, to activate a common identity process. And then the one that I think is the most interesting, maybe the most useful, but also the hardest to teach people to do, is to get them to think about how could you discover information about a patient that is counter-stereotypic, that is the opposite of the stereotypes about their group. For example, you may be talking to the most medically adherent patient on the face of the planet, but in fact, you need to look for information that would defeat the fact that you could perceive them as stereotypic. We take them through a perspective taking exercise, although I now call it perspective gaining, because I think that there are a lot of errors that can occur in perspective taking. And so we encourage them to ask information that reveals a patient's perspective. And then the final thing we do is we encourage them to create implementation intentions as to how they're going to use these strategies before they go in the clinic. So that's the list. That's basically the overview for what we do. Okay, what do we find? Well, in this study we did with medical students, the takeaway is with respect to the changes pre versus post across the various groups that we had in the study. And what you can see is that we find a significant attenuation of implicit stereotyping of Hispanic patients as non-adherent among majority group students. We do not find that among minority non-target students. And there is effectively no implicit bias among the minority target students prior to and after. So that was interesting that we were able to find changes on the IAT. And by the way, I should mention that was 3 to 7 days that they took that second IAT after the workshop. So there's a little bit of a delay in what we found. But of course, the question is, maybe you can change people's implicit responses on the IAT, but does that really translate into behavior? And so that was the goal of the second study that I'm going to tell you about. And here what we did is we focused on medical residents in internal and family medicine. You can see the demographics of the group there. And then what we did was we were able to recruit 366 Hispanic identifying patients, which comes out to about 6 patients per resident. And I want to just note that methodologically, the power of that is we're aggregating across patients. So we're not looking at one-off interactions between a resident and a patient. We're looking at a tendency the residents are showing across patients with respect to implicit bias. So what we do is we have the residents come in, they do the IAT, they do those resistance measures. We then had everybody complete the first material in the workshop, which is this awareness of what implicit bias is. And we did that on a video. It was a video of Katie Wolsifer, my colleague, and I talking about implicit bias and taking them through sort of the psychology of that and the research. But then we were able to randomly assign participants to either not get anything and follow them in the clinic after that, or go ahead and complete our in-person active learning workshops. So we're able to compare just being aware of implicit bias against being aware of it and then learning the active skills to control implicit bias. And then we follow them into the clinic where we consent patients. We leave a recording device, an audio recording device, so we have audio recordings of all of these interactions. And then we measure the patient satisfaction with the interaction with the resident, and we measure the resident's perceptions of how that interaction went. Okay, first thing is we find no main effect for our intervention and across any of the dependent measures that we collected. However, we find a number of significant interactions for what we're thinking of as resistance, individual differences in resistance to the materials. So what you see here is that implicit prejudice is moderating the effect of the training on patient satisfaction. And if when residents were low in implicit prejudice towards Hispanics, you see that if they got both the combination of awareness and active learning together, patient satisfaction was leaning toward higher compared to when they only were made aware. However, you can see that when they're high in implicit bias, patient satisfaction is lower when they get both the awareness and the active learning exercises compared to just awareness. Now, those simple effects are not significant, so it's weak, but the interaction is significant. The effect is stronger, actually, for explicit prejudice on the training effects. And what you see here is that it's the same pattern. Essentially, if they were low in explicit prejudice, the residents said that their interaction with the patient went better if they got the awareness and the active learning combo compared to if they just got awareness. But you can see for those who are high in explicit prejudice to Hispanics, they said essentially that they didn't think it went well if they got the combination versus if they got just awareness alone. We find that residents who believe that prejudice is immutable, you can't change it, residents who endorse colorblind ideologies, they say they're not using the workshop strategies. And then residents who prefer to escape interracial interactions, well, they're just not benefiting at all from the combination of awareness and active learning compared to just being aware. So I know I'm out of time. I'll just quickly summarize that the short-term effects are that we could change scores on the IAT with the workshop materials. That was effective for the predominantly white medical students, but not so much for the non-target minoritized students. But these longer term effects, when we follow the residents in the clinic, really depend on their resistance. And those who were low in resistance did much better when we did the combination of both awareness and active learning. But those who are high in resistance, well, they didn't like having to learn the new skills, it seems, and we saw less positive outcomes there. So As far as future research goes, in terms of the kinds of workshops that we've created, we think resistance matters. We need to understand resistance better. And certainly we need to think of ways of addressing resistance at the individual level. We need to talk about, prejudice is mutable. What's wrong with being colorblind, things like that. But I'll just finish by saying that I'm in total agreement with everybody today who has talked about systemic change and trying to change things from the top down. I'm a big fan of Keith Payne's work as well. I've been very influenced by that. I think we have to change the norms so that the people that are trying to make changes at the individual level can go into those organizations, and the bias in those organizations don't prevent them from making those individualized change. Okay, last thing I'll put up is just, I have a lot of great colleagues that have helped do this work, especially in our colleges of medicine and nursing at the University of Arizona, and I will thank you for the time.
Thank you so much, Dr. Stone. All right, our final speakers for the session are Dr. Lewis Penner, Professor Emeritus of Oncology at Wayne State University and the Karmanos Cancer Institute, and an Associate Research Professor at the Institute for Social Research at the University of Michigan, as well as Dr. Jack DeVideo, Distinguished Scientist and VP for Scientific Strategy with Diversity Science, and Carl Ivor Hovland, Professor of Psychology and Public Health Emeritus and Research Professor at Yale University. Doctors Penner and DeVideo will be addressing interpersonal interventions to reduce the effects of racial and ethnic bias in healthcare. And both Dr. Penner and Dr. DeVideo have contributed greatly to the literature on how racial bias contributes to health and healthcare disparities, evidenced most recently by their co-authored book titled Unequal Treatment, Anti-Black Racism and the Threat to America's Health. So please join me in welcoming Dr. Penner and Dr. DeVideo.
Hi, I'm Lou Penner. Jack and I will be co-presenting this in alternating slides, and Jack will begin with our presentation. Oops.
And thank you. Do have it? Good. Okay. Our presentation is very complementary to the 3 previous presentations and to many other presentations.
I think we're not seeing y'all's slides if you are trying to share them.
Oh.
I don't know.
Did you hit share? You didn't hit share.
Okay, now I'm going to bring it up.
You want me to share them?
Wait, let me get rid of that.
Mark can share them for you if you would like.
Yeah,
it seems that we need
ahead,
that.
Mark.
Yeah.
Hey, Mark, please share. Thank you.
Thank you, Mark.
Okay, so thank you for this opportunity. And Mark, can you go to the next slide? So our presentation is very much complementary to all the other talks that you've heard in this session and in a number of the previous ones. We begin with the basic premise that social biases contribute to disparities in healthcare and ultimately to health. So it's very reasonable for interventions to focus on reducing these social biases in terms of reducing implicit and explicit biases of physicians. We take a slightly different tack, but it's one that is very similar to what other presenters have said, is that what our tact is that our goal is not to reduce implicit or explicit bias directly, but our tact is to reduce the impact of social biases that physicians may have and patients may have on the outcomes of medical interactions and ultimately the quality of healthcare. And what we're going to be doing is presenting 3 studies. All of these studies are in the context of healthcare with health professionals. We're going to be talking about diversity training with physicians. We're going to be talking about a patient-provider intervention to increase Black patients' trust and medical adherence, and increasing Black active participation in medical interactions. And what's an important premise of everything we're doing is that doctors and patients are both active contributors to the medical outcomes and medical interactions in which they engage. And so we think it's important to think about the kinds of interventions that we do, not simply in terms of interventions with physicians, which is valuable, but interventions with physicians, interventions with patients and interventions jointly with physicians and patients.
You can't do that.
Oh, yeah, Mark, next slide. Now, the first study we're going to talk about is one where we tested the impact of an online learning experience developed by Diversity Science, and the participants were about 1,000 practicing physicians. And in this online learning experience, what was presented was research evidence of racial, ethnic, and gender disparities in healthcare and information on the psychology of bias. Now, we didn't expect information and knowledge to be sufficient to make change, but what we do know is that talking about disparities, making people aware about disparities, raises their motivation to do something to produce more equitable outcomes and more equitable behaviors on their part. And then a second part of this that's very important, and this aligns with what other people have said in this session, what we wanted to focus on was give people the skills, the capabilities, expand their capabilities by giving them strategies that are evidence-based to be effective at reducing, again, the impact of bias that people have on the quality of healthcare. So the goal is, again, not to reduce implicit bias. That's not the major purpose, but we want to focus on the outcomes and the behaviors. Mark, can you hit? Okay, and here's the results of the study. It's in this pre-post design. We had several different dependent measures. One was on knowledge about implicit bias. And you can see that there was a significant increase, but it was very weak. And one of the reasons it was weak is that providers already had a very high level of knowledge about this topic. But what the online experience did affect very strongly was their confidence, the depth of in their depth of knowledge about this and their willingness to explain this to other people. So it really affected not so much how much they knew, but that it affected how well they knew it. Then of primary importance is we had 3 different measures of behavioral intentions. One measure of behavioral intention was about strategies. We looked at their willingness to participate and engage in these behaviors and in their subsequent interactions with patients. And with the direct interventions, these were things that were directly measured, directly presented in the learning experience. And these were things like Dr. Stone just mentioned, perspective taking and creating a sense of common identity. A second type of behavioral intentions were things that were not explicitly mentioned in the learning experience, but were implicated. They were patient-centered behaviors. And the third type of behavioral intention was really a control, where it had nothing to do with the evidence about reducing the impact of bias, but we put that in there as a kind of measure of response bias. The results here is that this 30-minute intervention significantly affected people's behavioral intentions. It increased their behavioral intentions to engage in things like perspective taking with patients. It increased their intentions to form a common identity with them. It made them much more patient-centered in the actions that they were going to engage in. And it had no effect on irrelevant kinds of behaviors that was not evidence-based.
Mark, if you can advance the slide, please. In the 1990s, Jack and Sam Gertner proposed the common in-group identity model as a way to at least temporarily reduce intergroup conflict. And some of the speakers already mentioned this. Specifically, they proposed that different social groups could be made to change their in-group, out-group perceptions of one another to a perception of a common in-group identity with shared goals. This would increase intergroup trust and cooperation. We attempted to use this model to increase trust between Black patients and non-Black physicians. The setting was a primary care clinic in Northwest Detroit. Jack and Sam collaborated in a study, and this study was supported by an R21 grant that I received from NIH-wide. So the basic premise, one of the things we have to be very careful about when we talk about patient-focused interventions is not to do anything that would imply we're blaming the victim. The reason why you can address patients, the problem with problems associated with Black patients are the result of systemic and individual prejudice. And one of the consequences of that is that Black patients are less trustful of their physicians than our white patients. So as I said, we use the common in-group identity model to attempt to increase patients' trust in their physician. There were two groups. There was a common in-group identity group, and then there was a normal or standard of care group. In the common in-group identity, we provided them with team-themed verbal and non-verbal and written instructions. These were both presented to the patients before the interaction and were on posters on the wall in the rooms. We obtained from the, I'm sorry, there's an emergency alert where we are. Thank you. We also gave the patients and the physicians team-themed objects that we asked them to wear. So if you look in the lower left-hand corner, those are buttons that identify their team as a red, blue, or green team. And then they also gave them pens, which again, you can't see it well, but it says blue team working together as a team. The next slide, please, Mark. Okay, this is the results for the level of trust in the physician. Same day is really immediately after the interaction. And then 4 weeks is 4 weeks later via mail survey, and then 16 weeks later via mail survey. And the common identity condition is on the left and the control condition is on the right. And as you can see, initially, there are no differences. These trust questionnaires were given immediately after the interaction, and there's no reasonable patient immediately after the interaction, even though we told them anonymous, are going to indicate they don't trust their physician. But you notice at 4 weeks and 16 weeks, we get significant differences. Now let's move to the next part of this slide. This is medication adherence at 16 weeks. And what you can see is the self-report data is the patients in the common identity model report significantly more adherence than in the control or standard of care condition. Okay, we can move to the next slide, please. This is a study which was done by my colleague and co-author Susan Egley, led by my colleague and co-author Susan Egley. This was part of an NCI U54 award given to Terry Albrecht, who also happens to be my wife. Again, because of systematic and individual prejudice, Black patients are often less active in oncology interactions. One of this is that one of the manifestations of this is they ask fewer questions. The question prompt list is a technique which gives patients a list of questions that they could ask their physicians, and they're invited to bring them with them to the interactions with the physician. So we use the QPL to increase Black oncology patients' participation in interaction with their physician. We have the first graph, please. Okay, both of them came up at the same time. So what this shows is active participation, which is really the number of the questions that the patient asked. And you can see there's significantly more patient activity in the QPL than the control condition. And the second is a little more subtle. This is when they ask questions that prompted the physician to give them information. And when we get a significant effect, you notice that it's a much, much smaller effect. And this reflects both kind of the good news and the bad news. We can do this, but physicians are much harder to change than patients. Now I'm going to turn it back to Jack for the final slide.
Okay, Mark, thank you very much. So moving forward, which we'll try to do briefly here, I want to just argue, as we move forward, we have to again think if our objective is to improve the quality of healthcare, then we need to focus more on not just providers, but on patients and providers as members of the same team. Second of all, it's really important to start thinking about what are the conditions that really allow us to create enduring change in both physicians and patients, not only in their attitudes, but in their behaviors that make their interactions much more medically effective. And say the third and final point that I think we need to move forward on is thinking about not only working at the individual level of change, but begin to think about also the structural, as other people have talked about. So what is it about healthcare organizations or the policies they have in terms of number of patients that you have to see in a limited period of time? And do those structural changes mitigate or support the kind of individual changes that we're talking about? So we just encourage people to step back and look more broadly at the processes as we move forward. So thank you.
Thank you.
Thank you so much, Dr. Penner and Dr. DeVideo. So we will now transition into this discussion portion of our session. So I'll ask all of the speakers from this session, as well as our discussant, to turn on their video. And I will introduce our discussant, Dr. Sean Phelan, who is Professor of Health Services Research in the Division of Healthcare Delivery Research, and Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery at Mayo Clinic in Rochester. So Dr. Phelan's research program examines the impact of stigma on the delivery and quality of healthcare and healthcare outcomes, as well as factors that contribute to change in biases and attitudes about stigmatized, marginalized, and minoritized groups. Most of his research has focused on weight-based stigma and attitudes about people with larger bodies, but his work also targets race, gender identity, disability, sexual orientation, and other biases. So we now welcome Dr. Phelan to provide a few remarks and lead us in a discussion on evidence-based interventions to mitigate the influence of interpersonal biases on health outcomes.
Yeah, thank you. Thank you very much, Dr. Gilman. And thank you for the opportunity to be part of this session. So I'll start just briefly summarizing what we've heard across the presenters. We first heard from Dr. Lai, who presented a solution for implicit bias that relies on adding guardrails to decision-making and structures that can prevent the impact of bias on behavior. Dr. Cox then presented a training based on cognitive behavioral theory, that focuses on both motivation to be an agent of change and skills to empower change. And that one led to an 8-week sustained reduction in implicit bias, and as well as behavioral changes, including speaking up. Dr. Stone presented an awareness training coupled with clinical skill development for controlling bias. Some of the strategies for controlling bias included short-circuiting in-group bias through common identities or common goals, perspective taking, counter stereotypes, and behavior rehearsal. And found some interesting moderation effects, that the effect of the training was moderated by implicit and explicit prejudice and a few other factors, including having a fixed mindset towards bias and colorblind ideology. And then finally, Dr. Penner and Dr. DeVideo presented 3 different interventions. One, a diversity science intervention focused on reducing the impact of bias, that found some significant changes in understanding of the concepts and also intentions to change behavior. A common in-group identity intervention using team-themed instructions and colored items to develop trust in physicians, which was higher in intervention group. And also a question promptless intervention, where participation in the encounter was higher in the question promptless group, but especially when the physician was also prompted. So looking at all of them together, it looks like there's some commonalities for sure, and a few maybe important differences that we can talk about. So across all of the interventions presented, 5 are talking about affecting the impact of implicit bias rather than implicit bias itself, which I think is an important distinction. 3 of them were mediated by behavior change through either short-circuiting in-group bias, perspective taking, counter stereotypes, and other strategies. One was mediated by the behavior of the target of bias and the behavior of the bias perpetrator. That's the question prompt list one. And one mediated by rules or guardrails or systems that can head off the impact of bias. One affected implicit or aimed to affect implicit bias directly, as well as its impact on behavior, but by changing the way in which the education was provided. So instead of affecting the mediators of the connection between implicit bias and behavior, by really targeting moderation by the education strategy and by motivating and enrolling people in as common in-group members, it seems like, to empower them to be agents of change. And so some clear similarities, but some important differences too. And so I'll kick off with a question for everybody. And so the first question, if most of these interventions need to be mediated or better if mediated by a motivated participant, what's the benefit of creating felt need for change versus the risk of creating awareness and potentially motivating rejection of the message or some of those unintended side effects or consequences of teaching implicit bias that we see in kind of more non-scientific implicit bias interventions? Just jump in.
Yeah, feel free to just unmute yourself and jump in.
I'm happy to talk a bit about that. So with my former PhD advisor, Trish Devine, we have a book chapter that's answering exactly this question coming out in the Cambridge Handbook on Implicit Bias later this year. So as far as worrying about demotivating people, I often take issue with the term implicit bias. So very often people think, oh, well, this is something that's implicit. That means there's nothing I can do about it. I can't be aware of it. And then they kind of throw up their hands. So in our intervention approach, we very clearly talk about unintentional bias. And we're able to get people to understand that through very straightforward real world examples. We ask people, have you ever walked down the street and seen a Black man approaching you and had a fear response? Have you ever made an assumption that a woman in a medical context is a nurse rather than a doctor? Like basic kind of stereotype activation type things. People can immediately get on board with, yeah, I would kind of make that assumption. I would have that reaction. And I think sometimes the term implicit bias can push people to react negatively.
Yeah, Sean?
Yeah.
Can I just say something too that, I think we have to think a lot about the characteristics of interventions and how they're framed in the first place. And I sort of make a distinction between push interventions and pull interventions. By a push intervention, it's the idea of convincing people that they're not good and they should get better. Or it's about making some change that they may not see as benefiting them or society or even patients. And you get resistance to that. But we can think about also what I call a pull intervention, which is about beginning where people want to be at the end, which is the highest quality of healthcare, and then begin to think about these as tools that can help them get to where they want to be. So I think when you think about the motivation, you can't instill a motivation directly onto people who don't want to be motivated and want to resist it. You really have to meet the person where they are and figure out, I have this Pollyannish belief that people are good. And if you give people the right information, then they will want to pursue that. And there is research evidence that when people become aware of the racial health disparities, they become more motivated to want to do the right thing. So I think it really is, we have to start back a little bit earlier and say, okay, how is this intervention meeting the needs of the the person we're speaking to, and not assume that we can impose a motivation on them.
Can I add something to it? There's two things, and samples I've worked with are family practice clinic and then a large oncology hospital. And the two things that we ought to be is, first of all, generating reactants, because the social pressure on doctors, especially where we always had a very large African-American patient population, any suggestion that they might be racially biased, we do in a direct way, we do much more harm than we do good. The second thing, which is very practical, again, in at least the medical settings I've worked, is the pressure now on physicians to produce billable hours has gone up dramatically. I don't know if that's true in the institutions where other people work. And there's always a problem finding the time to do this kind of training. So the notion, at least in the environment I work, that we could pull them on a daily basis into a session where we do training is very, very difficult. My colleague Susan Egley did try to do that in a subsequent study, and it was extremely difficult to show them a film about changing communication patterns. So there's a very practical aspect to how you market or produce these interactions in a professional and medical professionals.
Mm-hmm. Yeah, there was a presentation yesterday, I think, where somebody talked about framing as a around the physician wellness. You know, if you want to enjoy your job more, if you want to, you know, have a, you know, as an alternate way to present or create motivation.
That's a very reasonable approach.
Yeah,
you have to be aware of that.
I guess add to that.
Go ahead, Jeff.
Oh, sorry, Calvin. Yeah, I can add to that by saying that we've worked a lot with our medical faculty to focus all the trainings that we've been doing on, you know, being the best doctor you can. So it's very much focused on an approach goal, right, as opposed to an avoidance goal. I think that's an important distinction. So, you know, but I don't know, and I'm sure everybody here that's ever done implicit bias trainings or workshops or education has had the experience of there's definitely going to be people in the crowd that no matter how you frame it, just don't want to have anything to do with it, right? And to me, that's sort of what we tapped into with this last study that we did, and identified some of the factors, I think, at least some of the beliefs that they have about how to deal with race and ethnicity and difference in the clinic that maybe we can start to build into addressing as part of our workshops. Because, yeah, I think the problem is if we go into it with the assumption that everybody's on board, right, we are speaking to the choir.
Mm-hmm.
There's definitely a percentage of the people there that are not on board with it. And if we can identify why they're not on board with it, then I think we can actually be more precise in how we address those pockets of resistance. To me, that's something I'm not sure how many people are thinking about that and the kinds of educational approaches they're taking. But that strikes me as one of the things to, you know, the next level of thinking about how to address this.
Kevin, go ahead. Yeah.
Yeah. So, you know, I feel like, well, I don't know if this is gonna be a hot take or like a lukewarm take, but I honestly think that, you know, some of these concerns about backlash are, I'm trying to think of a tactful voice. Well, I'm not gonna say very tactful. I think they're a little bit overblown because there's not that much data in the aggregate suggesting that it's happening that often. It seems to me, at least among professionals, like that the more common problem is a lack of engagement, of getting people involved and getting people motivated. So what I often see people worried about is apathy, right? Of okay, you just dumped all this information in my head, what am I gonna do about it? Or they told me these things I'm gonna do, but I'm not gonna do it. And so I at least in the ways that I often am thinking about like where the problem space is and where the solutions are, oftentimes what I think diversity educators, you know, really ought to grapple with is how do we just do better teaching, right? Because and we do have this chapter, I'm gonna paste it in the chat to do a little self-promotion that I haven't publicized very much yet, where we basically argue that there's a lot to learn from just like, what do we know from good basic teaching principles that maybe are not so often used in some of these kind of diversity education contexts. And I think that would help, you know, kind of proactively address some of these potential concerns about backlash, but also address the fact that a lot of people are coming in this room being like, I already know about implicit bias. Let's move on to learning about what to do about it, right? So I think that's how I would, I guess, like kind of reframe the question on my own kind of point of view, that a lot of it is ultimately a question of engagement and not so much oftentimes an issue of like someone kind of hunkering down on the spot, right?
Yeah.
I don't disagree with you at all. I think it's a very good point. My experience was when I would do grand rounds, maybe this is peculiar to the physicians I worked in an oncology setting. When I would do grand rounds, they would be, oh, wow, yes, implicit bias. And then they'd say, but you know me, I don't see a patient's race. And, you know, Jack once said, someone said that, and Jack made the comment, well, then you're unlike every other human in the world, you know, and so it was always a delicate balance. The other thing, which again may have been peculiar, is all our research was in hospital patient, and we really were at the mercy of the nurses and the physicians in terms of being able to do our work. So it's possible that we were too hypersensitive to the possibility of creating reactance or resistance.
Yeah, and I think that reminds me of what I often worry about the most, both as a practitioner and as a researcher, is that bias blind spot issue of it's everyone but me, right? That generates this apathy toward action.
Yeah, well, yeah, they don't need the training. Is that yeah. Oh, that was clearly that they didn't need the training.
And I think trends shift over time too. You might have, you know, suddenly, I feel like post-COVID, there's more eye rolling. Like everybody, we get it. Implicit bias is a thing. Might be a bigger barrier than kind of the anger you might have seen before that. Although, you know, the socio-political landscape is kind of ever shifting, and I wouldn't be surprised to see more and more anger towards these kinds of trainings as there are towards EID in general.
Well, knowing that we're getting to the end of the time we have for discussion, I was wondering if folks maybe want to offer any quick thoughts on the most important things we need to be thinking about for future intervention research in this area.
This is not quite what you're asking for, but I did want to highlight Michael Brownstein's question or comment in the chat about thinking about interventions involving structure-facing things. I think that's a great idea. One of the tensions is oftentimes diversity trainings are geared toward rank and file or the general employee population. It would be awesome, I guess, to get back to your question, if there were more interventions that were tailored towards, say, elite managers and so on, where you could be more tailored about structure-facing interventions.
And he just said what I was going to say. So, you have to recognize your existence within an organization, and you have to address structural changes that will either enable you to make the change, or more importantly, will enable you to sustain the change, because you have all sorts of factors, nothing else, inertia, which is working against the change being implemented and sustained.
Yeah, I might just be echoing what everybody's saying, but I've been giving a lot of thought to, we're doing a lot of individual training, right? And trying to change from the bottom up with the providers and anybody who, takes the workshop. But they run smack into the story I always hear after I do a training is a resident or medical student will come up and say, oh, I really thought this was great. I really want to try to do some of the things you're talking about. The problem is, though, I go on rounds or, rotation with my faculty advisor, and I see them do all the things you're telling us we shouldn't do, and now I don't know what to do. And what you hear is they're motivated to make change, but they feel that the structure that they're working in won't permit the change. And so, yeah, that's why I say I'm pretty convinced at this point that in order for any of these trainings to work, we've also got to be thinking about working from the top down to permit individuals to make those changes. How to do that, that's the key.
Well, thank you all. I know we're needing to move on to our next session now, but I want to thank you all so much for such a great group of presentations and discussion. So one more round of virtual applause for the speakers, and I'm going to transition over to Carlos.
Yes, hello everyone. Thank you so much for such an enriching, thought-provoking presentations and discussions. So as someone who's aware of the knowledge on interpersonal biases, someone who strives to really remain well-versed on the latest cutting-edge science, I certainly learned a lot. during the last few days. So at this point, I want to invite all speakers and discussants who are still online to turn on their videos. I now want to open it up for discussion for everyone to be able to contribute answers to the following 3 overarching questions that we're about to see displayed on the screen. So your answers may be based on points not raised on either the workshop, either the presentations, or in answers to prior questions. So consider points you want to encourage NIH to consider in the science of interpersonal biases as it relates to health. So why is this important? You have the opportunity to help shape the direction of federally funded science. So like our Deputy Director, Dr. Monica Webb-Hooper indicated, I received approval from a National Advisory Council late last month to work on a scientific concept to support research to understand the influence of interpersonal biases on health outcomes. So I will use your knowledge generated from this workshop to help fine-tune that scope of that notice of funding opportunity to be published in the future. So your contributions will help shape the direction of the science. So please feel free to raise your hand and answer any of the 3 questions that are posted on the screen. Dr. Krieger, yes.
Thanks. One thing that has come up across the many different presentations is the need for having in one sense of the term, multi-level approach. And that I would hope that the research that could be encouraged will ask people to engage with not only what is going on at the individual level, but the institutional context in which individuals work and the socio-political context in which this kind of research is being done. And there's certainly, and that would require obviously also interdisciplinary teams that can engage with these matters. Certainly there's a major concern about the relationship right now of political polarization in this country, what impacts that has on the behaviors of people, including elected representatives, and also what is occurring in relation to hate crimes and other kinds of biases that are happening, so that this work can't just be done as if it were in a vacuum. It's not. There's variation if it's framed in the US context across states in terms of numerous political metrics. We've certainly shown, and others have as well, this is mattering for what's happened with regard to COVID behaviors and COVID outcomes. And I think that it's just really important that whatever NIH prepares acknowledges that these biases exist within a very particular socio-political context within the United States, which obviously, of course, traces back to the history of being founded as a slave republic that's also involved settler colonialism. And these are realities that are still having their footprint on people's health to the present. So I would just very much encourage that it be framed as multi-level, that yes, it deals with interpersonal biases understood at the individual and also through the dyadic relationships that were being described in dyadic interactions, but it has to be these individuals are doing this usually within some kind of institutional context, whether it's a healthcare system, whether it's educational, whether it's in relation to carceral systems, et cetera, but it's doing it within a socio-political context, which is not unmeasurable, in fact, can be measured. There are also, for example, very important work that's been done, that's state liberalism policy indices that go back to, 40-odd years up through the present to be able to put things in trends and contexts. So that would be, I think, a very big plea that I would have, and that has to draw on the latest in good social psychology research, but also political science, political sociology, and then social epidemiology for tying things together through the ways in which that's what people do in their bodies.
Great points, Dr. Krieger. Thank you. Keep it going. Dr. Green, you're next.
I think Dr. Johnson was next.
Thank you so much. My background, my hand doesn't show up. So, so thanks, Dr. Green. I brought this up in the small group discussion, but I think it's worth noting in the large group discussion. We've had a lot of discussion around interpersonal biases and how they impact patients. But there's also a growing body of literature that shows that when Black patients are taking care of Black providers, there is a reduction in mortality gaps for both children as well as adults. But there hasn't been as much of this robust literature that we've been discussing on the impacts of interpersonal bias on health outcomes for how it impacts the providers. So I'm thinking about myself and my colleagues who have telomeres that are being shortened on a regular basis based on interactions we're having, not primarily with our patients, but with our supervisors and with our colleagues, and the impact that it has on our health and well-being, as well as our attrition out of medicine and science. And so I think that in our multi-pronged approach for improving health equity for marginalized populations, increasing diversity in healthcare providers is important. And so addressing the impact of interpersonal biases on the providers should also be an important area of future research.
Thank you very much, Dr. Johnson. Let's keep it going, Dr. Green.
Okay, I am next. Thank you for that. So a couple of things. One, I want to just jump off of what Dr. Krieger said before. I think we need better ways of measuring institutional bias and really looking at really how this variation in institutional bias is linked to population health outcomes. And so I study reproductive health, but there are a number of other outcomes, chronic disease, all those things that we could measure. I think a big gap in the literature, particularly for repro and other things, is the impact of team level biases on outcomes. We really focus on physicians when we think about who is facing patients and who has the most face time with patients. It's not physicians, it's nurses, it's physicians' assistants, it's nurse practitioners, all those other people. So I think it's really important to think carefully about how to conceptualize biases and attitudes among teams and see how that affects outcomes. And then I think the third thing, and I alluded to this before, is we really need to make explicit links between provider biases and patient outcomes. And what that might look like is linking that data to actual medical records, patient outcomes. I think, we sort of speculated a lot, but I think the next generation of research must explicitly link biases among individual providers, biases among teams, and their links to population health inequities. Again, as I said before, team bias is one thing, population level outcomes in health inequities are one thing, but why and how are those two things linked, I think, is so critical to answer. Thank you.
Thank you, Dr. Green. Appreciate it. Dr. Sabin and then Dr. Phelan.
Janice, you're muted.
I'm sorry, it's my first time today. So, Dr. Krieger's comments about the sociopolitical context, I agree. I think our entire society is under a tremendous amount of stress, but I also think the healthcare system itself, we were talking in our session about suboptimal, kind of climate and conditions, and I think the healthcare system is functioning at a suboptimal level right now. And, time is a commodity and pressure to see so many patients in a day. So I think there's just many stressors built into the system, and, they all need to be addressed. And the other thing I would like to mention, and it's some of the work that I'm doing now, is that I'm working with the informaticists in my department, as well as computer scientists, to actually, come back to this individual level, this, dyadic interaction, and think about how do we really look at whether or not implicit bias is being transmitted through more hidden processes, like, certain nonverbal communications and, just gaze and how people are moving around in the room. And using AI and social signal processing to, sort of automatically assess these things in an objective way to then begin to figure out how to address them. And so I think we need to sort of be very multidisciplinary and work with informaticists, computer scientists, and develop tools that can really advance this kind of interpersonal interactions and addressing it in, kind of an exponential way through technology.
Dr. Sabin, Dr. Phelan.
Yeah, I think one important research question or one important goal should be thinking about interventions, about the action of bias and how it affects care, how it affects behavior and health. Across different biases, again, across different targets of bias. The targets of bias differ in a lot of ways, including the degrees to which that biases are explicit, the degrees to which they're acceptable, that they're based on the perception of behavior being the fault of the person experiencing them. lots of different factors. And I think that consideration of how things that are developed to focus on, say, race bias more broadly might need to be specifically different for not just specific, race groups or ethnicity groups, but also wider bias towards, like what I study, weight bias, or bias towards people with disabilities, sexual orientation, minorities, things like that. Yeah.
Thank you, Dr. Fallon. Dr. Lewis Penner or Jack the Video, you're up next. And then I need to see more hands up. Please bring on the good feedback.
Yeah. Yeah. So I think one of the things that I want to just go back and emphasize is the idea of looking at providers and patients, and not just physicians, but providers more broadly as a unit, and understanding their interactions, and how physicians or providers might be able to bring out the best in their patients. Now, we have some research that we didn't present today that talked about how implicitly biased physicians, when they're interacting with the patient who is high on mistrust of the physician or of the medical system, creates a perfect storm where that interferes with the quality of care pretty dramatically. So again, I think that so many interventions are focused only on a physician, but begin to think about it as its own interpersonal system, and also what physicians can do, because they're in a high power position to really allay the concerns of patients, as Dr. Phelan was just talking about, and how do you address those reactions and counter reactions to one another?
Since Jack has his hand up, I'll add very quickly. One of the things that I keep stressing when I talk about this is, we have to recognize that while implicit bias is a very significant problem in healthcare disparities, there's also something called explicit bias, also known as racism. And a lot of times when I see interventions in organizations, everybody's focusing on implicit bias, and they don't look at, sometimes just staring you in the face is examples of explicit bias in terms of organizational procedures, some of the things that have been talked about by some of the speakers, and very quickly, sometimes maybe this is my cynicism, what I see in large organizations is that, oh, we'll do an implicit bias training thing, and that's the quick fix, and they don't look at the structure which perpetuates explicit bias, racism towards patients of color, or in the case if we're talking about gender or weight or things like that. That often is much more difficult and it's not addressed.
Thank you, Dr. Penner. Dr. Johnson, with the hand that totally hides within that the colors.
My hidden light-skinned hand again. I just want to piggyback on the comment from the other Tiffany on here, Dr. Green, and echo the importance of us linking the relationship between interpersonal biases on health outcomes, but recognizing the great challenge with that, because that is some of our colleagues' biggest fears. I'll say early in my career, when I was doing this research at one of the top children's hospitals in the country, unlike my colleagues who are allowed to release press releases to help disseminate their work, I was prohibited from releasing press releases, and it was put in an email that my research was a threat to the reputation of the institution. So I think that there is this fear of us exposing these biases, and the link that we know exists between patient outcomes is everybody's greatest fear, and why some of our institutions don't want us doing this work. So I think there needs to be more work on how we create a culture similar to the patient safety and quality improvement culture, similar to doing, morbidity and mortality reviews, where we do root cause analysis on how, what the systems were that contributed to these poor outcomes for patients, and how can we take those models and apply them to interpersonal biases and kind of destigmatize it in a way where we can actually impact change, because people are so fearful for engaging in this work because they don't want their biases to be exposed.
Excellent points, Dr. Johnson. Dr. Mendoza-Denton, I noticed that you had your hand up. Do you still want to contribute your comment?
Thank you. I was waffling because I think a lot of what I have in mind has been said. Just piggybacking off of Dr. Penner's comments, specifically mentioning organizational features, and then Dr. Johnson's comment about how contexts are able to potentiate or manifest the biases. So while I'm all in favor of multi-level approaches, I really want to sort of stress this idea of the organizational features of the settings that facilitate the biases, and I think that a focus on that can help mitigate the resistance or the apathy where people don't feel like they are being personally blamed. Now, that's very much in contrast, and we heard this from Dr. Stone, that to the strong individualistic approaches, individual level bias, et cetera, and some funding dollars towards the top-down approaches would be, I think, really helpful. I had put my hand down because I think it's sort of been said, but I'll just say it again since you caught me with my hand down.
That's great. Thank you, Dr. Mendoza. Then Dr. Krieger, then Dr. Stone, you're next.
Thanks. Back to what the NIH might fund is just also, again, hearing this conversation and being aware of people in my department, not myself, that do some of these kinds of intervention studies, is having NIH also be funding research to evaluate what the policies are of institutions in relation to what's playing out with regard to both overt and also other types of implicit racism and other forms of discrimination, so that there can be a focus on the institutions themselves and what the policies are and what that means for outcomes. And presumably there should be some time series data that can be evaluated in this way, given some of the attempts to get changes in institutions. So I hope that the focus can be that the institution can be the unit of analysis, and the outcomes amongst people that are affected by those institutions can be one of the outcomes considered, and not only have it be based on individual level data.
Thank you, Dr. Krieger. Dr. Stone, you're up next.
Yeah, I totally agree with Dr. Krieger. I think I was thinking the same thing. I want to make a pitch that I'm not sure I've heard just yet about supporting research that's more about improving our methodologies for tapping into interpersonal bias. There's advances being made all the time, for example, in the use of the IIT. Jordan Axe's talk was just great today on examples of the kind of work that's going on in social psychology, just trying to advance our understanding of the measurement side of this. And I feel sometimes like I would love to propose something where I'm going to play a little bit around with how best to measure the bias as it's happening in the clinic, right? Some of that work is looking at, I said we have recordings, we're looking at nonverbal behavior, we're looking at language, for example. Some of the analyses of how to do that are evolving all the time. And I feel like a lot of times we're so focused on making sure that we're tapping into patient outcomes as the most important outcome of the research we're doing. And it is. But at the same time, support for the basic research side of it would also be helpful for everybody that's doing research, trying to understand how best to capture these phenomenon that we're so passionate about trying to do something about, right? And part of that was what Dr. Krieger just talked about is, if you were going to measure change at the institutional level, structural change, right? What are the measures for that? We know how to measure individual thoughts about structural change, but how do we actually measure the change at the structural level? And that to me is the really interesting thing we have to be thinking about. Thank you.
Thank you, Dr. Stone. I can't thank everyone enough for sharing their contributions, their insights, their cutting-edge science. So as we brought this enlightening workshop of interpersonal biases in health to a close, I'd like to reflect on recurring themes for day 2. So one of the predominant themes that we heard about were the intricate pathways from exposure to biases and minority stress to potential clinical outcomes. So we examined mediators, we heard about mediators like biological functions, and moderators like coping mechanisms, and how they influence the link between bias exposure and health. The biochemical stressors and epigenetic regulation leading to age-related disease further underscore the profound impact on chronic stress from bias exposure on health. These biases extend to various forms of discrimination, such as the coercion faced by minority women of color living with disabilities regarding contraception. Another recurring theme is a pervasive anti-Black bias observed in pain perception, even among healthcare professionals. We've delved into complexities and challenges in measuring implicit bias. While predictive validity of implicit bias measures remains contentious, innovative statistical approaches like structural equation modeling show promise in mitigating some psychometric challenges. Implicit measures have also been used to study multiple discriminations, highlighting the associations between implicit and explicit racisms through novel meta-analytic methods. The philosophical perspective that we must address both the individual and structural changes concurrently has resonated throughout our discussions. It's not just about choosing one over the other, it's about understanding the interaction between changing minds and changing systems to affect change at a comprehensive level. So a significant breakthrough discussed was the first study linking daily exposure to interpersonal and other forms of stress, bias, and discrimination to blood pressure, illustrating the dynamic and complex nature of discrimination impact on health across different demographics. Weight stigma, another critical research area, has been linked to poor health outcomes through physiological or psychological, behavioral, and physiological responses. Additionally, the role of nonverbal synchrony on the basis of race-related attitudes during cross-group clinical interactions was highlighted as a subtle yet significant way of gleaning the impact of bias in quality of clinical interactions. The impact of biases on children, including structural biases, was a significant focus. The ways in which biases influence discriminatory behaviors across various contexts, such as schools and neighborhoods, were also examined. And lastly, in terms of interventions, one key approach discussed was the implementation of guardrails and boundaries to constrain decision-making and introduce checks to mitigate biased actions. Another promising strategy was the habit-breaking training, which leverages cognitive behavioral and organizational change methods to create lasting change. Also, tailoring educational materials to the medical profession and presenting them to medical students was highlighted as an effective evidence-based approach. Overall, the focus on reducing implicit bias in healthcare to address disparities was a central theme, underscoring the need for comprehensive, multifaceted interventions. So I want to take a moment to express my heartfelt gratitude to everyone who has contributed to making this event a remarkable success. First and foremost, a big thank you to our esteemed speakers and discussants. Your thought-provoking presentations and discussions have provided us with invaluable insights and have sparked meaningful discussions that will undoubtedly drive our work forward. Your expertise and dedication are deeply appreciated. To our moderators, thank you for skillfully facilitating and guiding us through the complex topics and with clarity and thoughtfulness. I'm genuinely satisfied with the dynamic and productive conversations that we had over the last 2 days. The exchange of knowledge and experiences have been both inspiring and enlightening, and your contributions have been invaluable. And I'm grateful for the collaborative spirit that everyone has brought to this workshop. So as we move forward, I invite you all to email me with any additional input or reflections you may have. Ongoing insights are important, and I will carefully consider all these knowledge generated from this workshop. So I'm excited to inform you that this invaluable input will be synthesized and implemented into the upcoming notice of funding opportunity. And together, we will continue to advance our understanding and work towards reducing health disparities by reducing interpersonal biases. So thank you again for your dedication and participation, and I look forward to our continued collaboration in the impactful work that lies ahead. Thank you.